invite IT to play the anthem.
Stand and sing, O Zambia, proud and free, land of wake and joy in unity, victors in the struggle for their right. We've won freedom's fight, all one, strong and free. Africa is our own motherland, fashioned with and blessed by God's good hand. Let us for her people join as one, brothers under the sun, all one, strong and free. One land and one nation is our cry. Dignity and peace need Zambia's sky. Like a noble eagle in its flight, Zambia, praise to thee. All one, strong and free. Praise be to God. Praise be, praise be. Bless our great nation, Zambia, Zambia. Free men we stand under the flag of our land, Zambia. Praise to thee, all one, strong and free.
Thank you. While we're still upstanding, I'll invite Miranda to come and open for us in a minute of prayer.
Our kind and loving Father above in heaven, Jehovah God, we want to thank you for being with us throughout the week. Jehovah God, even as we gather in this manner, we also want to thank you for bringing us all to this place because we knew that today we're going to gather in this manner. We invite your presence in us because of very important agendas of our region. Mighty God, be with us and help us to deliberate and faithfully. Where we discuss, going to bring about development. We ask for this in the mighty name of Jesus. Amen.
Thank you very much. We may take our seats. The guest of honor, the Permanent Secretary in charge of Technical Services in the Ministry of Health, Zambia, Dr. Kennedy Lishimpi, the Director General for East, Central, and Southern Africa Health Committee, Dr. Ntuli Apologwe, the Senior Health Specialist, World Bank, Health Emergencies, Pandemic Preparedness and Response, Clementine Fu, the Regional Advisor for Country Readiness Strengthening, WHO Afro, Dr. Charles Kuria, distinguished permanent secretaries from ministries of health across our region, the Director Generals for National Public Health Institutes present this morning, the Director in charge of Public Health, the Ministry of Health, Dr. Matilda Simpongwe, representatives from World Bank, WHO, IGAD, all developmental partners, civil society organizations, the media, distinguished invited guests, ladies and gentlemen, good morning. Good morning. A warm welcome to all of you to the Global Health Diplomats Workshop, which is being held under the theme, Leveraging the Pandemic Agreement, Revised International Health Regulations 2005 and the right to health to advance Africa's global health diplomacy agenda. I'll take you through the agenda for the official opening of this meeting, a one-day meeting. So as we start our meeting, we're going to have remarks from the Executive Director from EXA, to be followed by remarks from WHO, and then thereafter we're going to have remarks from the World Bank, and then the Permanent Secretary in charge of Technical Services is going to officially open the meeting. I'll be your Director of Program for this official opening, and my name is Dr. Kalangwa Kalangwa. So without much ado, join me in welcoming the Executive Director for East, Central, and Southern Africa Health Community, Dr. Ntuli, as he comes to give his remarks. A round of applause as he walks to the podium.
Thank you very much, Director of Programs. Dr. Kennedy Lishimpi, Permanent Secretary, Technical Services, from the Minister of Health of Republic of Zambia, and our chief guests, permanent or principal secretaries from different ministries of health, the World Bank representative, my sister Clementine, WHO Afro representative, Dr. Charles, Dr. Matilda, Director of Public Health from the Ministry of Health, Zambia, directors and senior government officials here present, distinguished guests, representatives from different organizations, including our development partners, our facilitators of today's workshop, ladies and gentlemen, bon dia, bonjour, mulibwanji. Good morning, everyone. Honorable guest of honor, it's truly my pleasure, indeed it's a privilege for me to stand before you here in Chongwe district as part of Lusaka province. I've learned that today. I thought this was Lusaka, only to realize that this is a Chongwe district, part of the Lusaka province. Thank you very much, Chief Guest, for that. On behalf of East, Central, and Southern Africa Health Community, and on my own behalf, I would like to take this opportunity to welcome you all to this very, very important workshop on health diplomacy, themed leveraging pandemic agreement, the revised International Health Regulation of 2005, and the right to health to advance Africa's health diplomacy agenda. Guests of honor, allow me to begin by expressing my sincere appreciation to you and the government of Republic of Zambia for the generosity in hosting this important meeting and for their unwavering commitment to strengthening regional health cooperation through health diplomacy. We are truly grateful for that. My other thanks goes to the permanent secretaries who have given this workshop a very, very big weight to attend, but also to our partners from ECONET, WHO, IGAD, and others. Ladies and gentlemen, this workshop marks yet another milestone in EXA Health Community's journey to strengthen regional cooperation, leadership, and our collective voice in global health affairs. As the global health architecture evolves through the pandemic agreement, the amended International Health Regulations of 2005, and an ever-shifting geopolitical landscape, we must ensure that Africa's priorities remain firmly at the center. This must be a space where our concern shape our regional and global discussions, where our innovations influence global decisions, and where South-South cooperation becomes a powerful engine and tool in advancing our shared aspirations. Ladies and gentlemen, through this workshop, we aim to equip a permanent or principal secretaries, health attaches, senior government officials, and other partners who, in one way or another, are playing part in decision making. We believe through this workshop, there will be several things that are going to be learned from understanding the implication of pandemic agreement and IHR 2005 that was amended in this year for our African region, advancing the right to health and equity within the global health architecture. Third, strengthening Africa's collective negotiating power through regional solidarity. Fourth, identifying strategies to integrate global health diplomacy principles into national and regional governance structure. And last but not least, enhancing lobbying, etiquette, protocol, and effective communication capacity. Guests of honor, this workshop is not only a platform for learning, it is a strategic space for action, a space where policy commitment evolve into concrete collaboration and where ideas are transformed into shared regional strategies. Guests of honor, I'm also very much pleased to announce that EXA will soon be launching a certificate short course on health diplomacy. This course will target lower to mid-level health and non-health professionals, ensuring that the foundation of global health diplomacy are under
institutions have put into driving this agenda. And we recognize that it is not only a priority, but a need, an essential, critical need for us to look at the threats that face this continent, as well as the impact to the rest of the world. Africa sits at the center of not only pandemic and epidemic risk, but also as a model for other regions to look at the collective spirit and collective action that we need to address all of these threats. I want to take a moment to think about global health diplomacy, the reason that we are here today. The pandemic agreement, the amendments to the international health regulations, they have been major achievements in collective multilateralism, in commitments to this agenda. And I want to congratulate as well all of you in this room who have contributed to the development and the agreement of those achievements. But at the same time, developing those, agreeing to those is one step. Implementing them is the next. And how we do that depends on what we'll discuss here today in this room, as well as what we'll do when we go back to our respective countries and institutions. Making progress not only on the health emergency and pandemic preparedness and response agenda, as well as the wider health commitments and sustainable development targets that we've made as countries and as a global community, depends on ensuring that we have multilateral and bilateral and progress towards the commitments that have been made in the IHR agreements and the pandemic agreement. I have spoken about this, in fact, earlier in the week, but for those of you who did hear about it, I beg you beg your patience. But last week, the World Bank also held a convening in Indonesia, where myself, a few other colleagues, joined with 15 or so other countries from across Africa, as well as other regions, to discuss critical topics in health emergencies and pandemic preparedness, including governance and financing. Our hosts there in Indonesia, in fact, spoke and welcomed us with the notion of mutual aid, where Indonesia has a culture of mutual aid, of working together from across government institutions, from across partners, to within communities to solve problems. But with all due respect to, I think, our Indonesia colleagues, I don't think, in fact, that is unique to the Indonesian spirit. In fact, it's seen no better place than here on the continent of Africa, where we do have mutual aid, collective action, and commitments to work together as a continent to address the threats and agendas that we have today. And so I want to take that notion with all of you to make a commitment in this room, in this workshop, as we go through the important discussions that we have today, to really promise each other that not only are we here to drive forward and make better the health, social, economic well-being of our individual populations, but of all of us as a region, as a continent, and with all of the institutions and partners here to support you as well. That mutual aid is not something that is unique to one country or one culture, but as a continent, that we have the collective resources, the collective spirit, the collective motivation and drive to really achieve what we need to do to implement the amendments and the pandemic agreement. Thank you to all of you for joining here today, and we look forward to the progress and actions that will come out of the workshop. Thank you.
Another round of applause for Clementine Fu for those remarks, indeed reminding us the importance of ensuring that the developed agreement, we work hard and together to ensure that it's implemented. And this can only be done if we work together as a region. Distinguished guests of honor, ladies and gentlemen, I will now invite our director in charge of public health in the Ministry of Health, Zambia, Dr. Simpungwe, to come and invite the guest of honor to speak. A round of applause as she walks the podium.
Thank you so much. It is now my singular honor and privilege to invite our Permanent Secretary, Technical Services in the Ministry of Health, Dr. Kennedy Lishimpi, to deliver his speech.
Good morning, colleagues. I was asking the Director of Public Health why she did not say anything. So she just smiled. She didn't answer. As I was coming here, I was mastering a line in Swahili, but just from there to here, I cannot recall it. I wanted to thank the speakers in Swahili for the good speeches that they have made this morning. And I was going to say, they have made me very happy this morning. Now, I can't remember everything. So today we are happy to be here for the Global Health Diplomacy Workshop, the 20th of November, being held here in Chongwe, Chongwe District. So I want to recognize the presence of the Director General for EXA Health Community, Dr. Kapologwe, the permanent secretaries who are here from member countries, the World Bank Senior Health Specialist, Dr. Clementine Fu, and the WHO Afro Advisor for readiness and strengthening of pandemics, Dr. Charles Korea Tuguna, and also the Director Generals from the National Public Health Institutes that are present here, the other representatives from the World Bank, the World Health Organization, IGAD, and EXA community, health community, development partners, civil society, ladies and gentlemen, members of the press. Good morning. On behalf of the government of the Republic of Zambia, and on behalf of the Minister of Health, it is my honor and privilege to welcome you to Lusaka and Chongwe for this important global health diplomacy workshop. By the way, when you stand outside there, if you've got very good eyes, you can see the airport across on the other side. Or if you've got good cameras, you can zoom in and see it nicely. We are delighted to host such a distinguished group of leaders, experts and partners who share a common commitment to strengthening Africa's role, voice, and influence in global health governance. This gathering comes at a crucial moment for our region and the world. The COVID-19 pandemic reminded us that health challenges transcend borders and that Africa must not only respond to global decisions, but play an active and strategic role in shaping them. Global health diplomacy provides a powerful platform for our governments to negotiate, influence, and align national and regional health priorities with international frameworks. It ensures that global agreements truly reflect the realities, aspirations, and the needs of African countries, our disease burden, economic context, and human capital, and that the right to health remains central to all international commitments. This workshop builds on more than a decade of work led by EXA Health Community since 2010, following the 50th Health Ministers Conference in Kampala, which called for stronger negotiation capacity across our member states. Today, we meet shortly after two landmark developments adopted at the 2025 World Health Assembly. The first one is the Pandemic Agreement, which establishes a new legal framework for pandemic prevention, preparedness, and response, grounded in equity, access to technology, transparency, and solidarity. The second is the revised International Health Regulations, IHR 2025, which strengthen global health security through early information sharing, One Health integration, and sustainable financing of core capacities. These new frameworks present both an opportunity and a responsibility for Africa. They challenge us to ensure that implementation not only builds preparedness and response capacity, but also strengthens our health systems, protects our communities, and amplifies our collective voice in shaping the future of global health governance. This workshop is therefore timely and essential. Over the course of our deliberations, we aim to strengthen the capacity of senior officials to engage more strategically in global health negotiations. We will deepen our understanding of the implications of the Pandemic Agreement and the International Health Regulation of 2025 for our countries, identify opportunities for regional collaboration, and reflect on how Africa can speak with a unified voice in global platforms such as the World Health Assembly, the World Trade Organization, and the United Nations General Assembly. Through dialogue, plenary discussions, and focused working groups, we will explore how global commitments can be integrated into national systems, particularly in pandemic preparedness, financing, innovation, technology access, One Health, and upholding the right to health. As highlighted by the Director General for EXA Health Community, today's program is designed to help us define clear regional priorities, strengthen both technical and political negotiation capacity, and reaffirm our shared commitment to building resilient, equitable, and sustainable health systems across East, Central, and Southern Africa. Distinguished delegates, the world is watching how Africa positions itself within this evolving global health architecture. Zambia remains deeply committed to working with EXA Health Community and all regional partners to build health systems that are resilient, equitable, and self-reliant systems capable of withstanding shocks while ensuring the well-being of our people. Let this workshop serve as a reminder that diplomacy is as essential to health as any vaccine or medicine. It is through collaboration, dialogue, and strategic engagements that we will secure a healthier, safer, and more prosperous future for our region. I usually like to add this last statement to speeches like this one. If there will be one scientist among us living today who will discover the vaccine against poverty, that is the one who all people who have held Nobel Prizes must surrender them to. I wish you all fruitful deliberations and successful workshop. Thank you very much.
Another round of applause for our guest of honor. Indeed, for officially opening this meeting and also encouraging everyone to actively participate in the deliberations so that we fully understand the pandemic agreement and the international health regulations of 2025 so that we're able to speak with a united voice as Africa. Distinguished participants, guests of honor, we've come to the end of our official opening program. We're going to proceed outside for a group photo. I'll invite all to be upstanding and invite the high table to take leave. So all of you are going to join in the group photo. Thank you.
Test. 1, 2.
So as we proceed with our meeting, I'll invite Mr. Sibusiso to come and take us through the meeting objectives and the strategic importance of this meeting for the region.
Thank you, Program Director. Good morning. Yes, please allow me to ride on the protocols that have been established before. Of course, recognizing our chief guest, the PS, and also mentioning that today we are joined by 3 of our member states. That is Lesotho, the Kingdom of Lesotho, the Deputy PS, then Mauritius, who joined us today, represented by Mr. Mawa, who is the Acting Senior Chief Executive, and Zimbabwe, Dr. Simbi, who is the head of the NPHI. They were not with us in the past 2 days, and they've just come in today for the global health diplomacy. I will just quickly go through the slides, and I noticed that our high table actually did a very good job, a super job, because most of what I was going to say has already been covered. So I will just quickly go through the slides so that we make good use of the time. If we can move on to the objectives, workshop objectives. Yeah, so we have 4 of them, and this has been spoken to. We want to ensure that our senior officials have the capacity in global health diplomacy and basically the capacity to engage and negotiate at a global level. We know that, of course, that capacity already exists, but it's more like a reorientation of those capacities. Then, of course, review and debate the implications of the pandemic agreement and revise IHR for African countries. This will be presented by our facilitators. Then, of course, develop some regional negotiation positions. Hopefully, we are able to do that through this workshop, looking at the issues of reflecting the rights-based approach to health within key global platforms. And lastly, promoting the intersectoral collaboration and regional coordination of effective agreement implementation. Next slide. So that is the expected outcome. So enhanced capacity, some clear regional negotiation positions following the discussions that we are going to have today. Then strengthen communication between Geneva-based missions and national ministries. I think this is also a very important one, looking at how we can approach this in a more strategic and systematic way, how we make use of our Geneva-based missions as part of the negotiations. And lastly, having some actionable recommendations to operationalize the right to health through treaty implementation and regional health diplomacy. Next slide. This was covered by our program director of programs. Let's move on to slide 7 and 8. I'll speak a bit about the genesis of the Global Health Diplomacy Program, which our chief guest also spoke to within the EXA region. Now, the issue is that there were concerns over inadequate preparations of key international meetings. So these concerns were raised in several platforms, and looking at how this can be further strengthened, because it was also recognized that there was uncoordinated follow-up on key resolutions, and there was no linkage with national policy formulation. So that was the one issue in terms of why then we came up with the GHD program. Then, of course, the need for capacity strengthening, especially amongst senior officials, and also providing the required information, as well as coming up with sustainable institutional arrangements in the region so that there is effective participation in international negotiations that affect global public health. So these were the issues which led to the GHD program. And of course, today we are talking of the IHR, we are talking of the pandemic agreement, but there are several other agreements that exist and other issues in the global health space which require us to have the skills for negotiation. Some of you will know about the Doha Agenda, will know about the trade-related aspects of intellectual property rights, that is the TRIPS, the GATS, the climate change issues, access to medicines, health worker migration. Some of you may remember the Code for International Recruitment of Health Workers, which was deliberated over long periods of time and which required long negotiations, especially from African countries who felt they were being disadvantaged by the migration of health workers to overseas countries. So these are all the issues, but for today we'll just be looking at IHR, of course, and pandemic agreement, but there are so many other issues that we need to be prepared for so that we can engage effectively. Next slide. So the three main features, of course, is that there's low awareness on the role of GHD in national health security. There's inadequate collaboration between institutions and main actors in GHD. So we are looking at ministries of health, we are looking at ministries of foreign affairs and trade, and many other institutions. So we want to make sure that these institutions are able to work together. And of course, the training aspect in public health and diplomacy in the region. Next slide, we can go to slide number 19. So that I think this one, our chief guest spoke to, because all these issues I'm talking about, they led to a resolution that was taken by the ministers in 2010 during their meeting in Kampala in Uganda, where they decided that in order to be able to negotiate effectively in these global platforms, we needed to introduce the Global Health Diplomacy Program for senior health officials, so that it involves not only just senior officials, but also the health ministers from the countries, so that they can be able to address all the health issues that affect the region. Next slide. So that is the resolution, which I will not really go through. So we have some strategic partnerships that we have come up with, because EXA will not work alone in this area. We have partnered with Equinet, I think, for quite some time, where we offered some training programs in the past. We also came up with a directory for GHD. And also the University of Nairobi in Kenya came up with a training program on GHD. And most recently, we partnered with best diplomats who are based in the US, as well as the University of Memphis. I think the DG talked about a program that will be introduced very soon on GHD training, collaborating with the University of Memphis in the USA. So these are the strategic partnerships meant to strengthen GHD. Let's go to, yeah, you can move along. Go to slide 19. Yes, please. Yes. So we are saying, and this has been mentioned by Dr. Njuguna, that we need to be speaking with one voice. What we are saying here is there should be a stronger mandate for diplomats. So we need to be shifting from the national ideas to getting into regional ideas. And we also need to look into how we engaged with the African Coordination Group in Geneva, because it is central in this process. We need to make sure that there's a stronger link. We need to enhance the role of the health minister, who is usually the head of delegation, both as a national leader and a regional consensus builder, leading, of course, some of the regional blocks within the region, and ensuring that there's advocacy that is being built in places like Geneva. So what we are saying is EXA is considered as a regional layer that is a decisive factor where politics meet technical policy. And it is not just EXA, but we are also looking at other regional institutions which form a layer, making sure that politics and technical issues talk to each other and decisions are made in a more clear manner. Then we can go to the next slide. Yeah, so looking ahead, what we are thinking as EXA is that we are going to be revitalizing the training programs on GHD. As we have mentioned, we are going to be building stronger linkages with the Geneva-based embassies. And I should say, I think Bonnie later on is going to be introducing our facilitators. We have already started the process because we have colleagues who have been based in Geneva, who are based in Geneva, and who will be also taking us through and telling us how these processes work. So we need to have that kind of strong linkage so that we are able to play this role more effectively. The African voice, definitely, this has been mentioned, we need to strengthen it in terms of global diplomacy and also monitor what is going on and expand the EXA GHD network. This is also something that we are working on because we cannot work on this alone, but we need other partners, other key players who can actually support this endeavor. Next slide. We'll be producing some briefs, policy briefs. We'll be looking at coming up with some research priorities. There are many issues that need us to actually look into, investigate, and understand how certain things happen. So we are going to be coming up with these research priorities and also prepare some discussion documents on the instruction, of course, of our principals from the member states, like which discussion documents are important to guide the process of negotiation in Geneva. So all in all, I think all in all, we want to make sure that this initiative gets grounded in existing EXA systems, the governments, institutional programs. We want to exploit synergies, build complementarities, create awareness, and of course improve recognition, commitment, and advocacy through this initiative. And as a last slide, in conclusion, I want to say the fundamental issues when it comes to the GHD is that we need to be advancing the African agenda in global health. You are going to hear later on how that has been happening, but we need to be stronger in terms of how we advance that agenda. Because the question is, why should we care about a pandemic agreement somewhere? Why should we care about an agreement happening at a global level instead maybe of focusing on drug shortages or whatsoever, what's happening at a national level? How does that affect what we do at a national level? So we need to be thinking about this so that we can advance our voice within that space. Then, of course, making sure that we negotiate global policies in alignment with our national goals. So that is the one aspect, and also engage in South-to-South cooperation. So these are the fundamental issues. And of course, we have talked about speaking with one voice, as it has been mentioned before. So there needs to be a stronger, more coordinated political and technical role for regional organizations as well as the countries, as we try to influence what is happening within the global health space. So all in all, that is it. I think I was supposed to take 2 minutes, but somehow it got to, I think, about 6 minutes. But thank you for listening.
Thank you very much, Mr. Sibusiso, for that overview. I think it's quite clear the importance of this meeting and the skills that we need, even as we go and have the discussions, how we look at ensuring that we ahead our national agendas, even as we discuss these global pandemics. and ensure that our agenda is always put forth as we discuss. I'll now invite Dr. Tina Chisenga to take us through the orientation of these meetings, the Global Health Diplomacy Focus, the Pandemic Agreement, the revised International Health Regulations of 2025, and the right to health.
Good morning. Good morning, everyone. As I've been introduced, I'm Tina Chisenga. I'll take you through just a brief overview because I know the facilitators are really going to dive into everything about the pandemic agreement, the negotiations that are currently going on, the amended IHR, as well as the right to health. Just waiting for my, okay, there we go. So that's the objectives of my session, just really going through the three items and also looking at how we can support informed engagement for decision making. Next. I know that the scene was set when the speakers spoke earlier in the opening session, but just to give you a little bit of a summary of what was said earlier, is that this discussion is really important at this particular moment. We know what we went through during the COVID-19. We know what we've been going through, even with the current outbreaks that are on the face of Africa at the moment. And it's really showing that there's some weakness in some of our health systems. There's also a very renewed focus on prevention and preparedness. Our speaker from World Bank did talk about how they're supporting more preparedness and prevention aspects of health moving forward. Dr. Njuguna did mention that there are still ongoing negotiations on the pandemic governance. This is going to be an ongoing conversation at the World Health Assembly, even in the different fora that we're going to be meeting moving forward. And also the critical role of health diplomats, it cannot be understated. We need to really ensure that our health diplomats are empowered with information and are supported from capital to make sure that whenever they are participating in these negotiations, it speaks to the need of the countries, the need for the Africa region, as well as the need of global solidarity. Next slide. So just to give an overview of the pandemic agreement, I think most of you have been having these conversations starting from 2021, just when the COVID-19 pandemic hit. The conversation started within our executive board at the World Health Assembly, World Health Organization, all the way to the World Health Assembly. And finally, we had an agreement that was endorsed this year. But just to also highlight that this conversation is not over. We continue to have conversations on the annex of the pandemic agreement. And this is really focusing on the pathogen access and benefit sharing. We are lucky today that one of our facilitators is actually a representative for this negotiation body, Ambassador Vuyile, who's going to be speaking more on this topic. So just to give a brief on the agreement at the moment, it focuses on specific key areas: strengthening preparedness, looking at surveillance and response, and while addressing equity issues, to access to medical countermeasures, as well as promoting the One Health approach that links human, animal, and environmental health. So this pandemic agreement goes beyond just the health aspect, but also looks at the animal side, the environmental side as well. Next slide. When it comes to the amended IHR, it really highlights how we can strengthen global health security. There were some gaps that were noted within the IHR, and this has really made the amendment stronger in terms of making sure that there's a pandemic emergency level alert that is heightened. It also opens up the requirement for the national IHR authority within our countries and having this enhanced frameworks for implementation and equity. Next. All these negotiations have been going on at the background of what has already been existing. We continue to talk about how we need equity, but we have already appended our signatures to important frameworks that look at the right to health. One example is the Universal Declaration of Human Rights. So this framework looks at fundamental human I think we're back on. Yes, thank you. So this framework looks at the fundamental human rights to be universally protected. So even when we have conversations surrounding the pandemic agreement and IHR, let's also bear in mind that we have these existing right to health frameworks that protect human rights, and health is a human right. The second framework is the International Covenant on Economic, social, and cultural rights. So every country has an obligation to provide its citizens with fundamental economic, social, and cultural rights. Rights to work, education, and an adequate standard of living, including sufficient food, housing, and healthcare. So as we have these conversations, please remember these fundamental frameworks that we have appended our signatures to. Then there's also the AAAQ principles. So the AAAQ principles really focus on availability, so having available resources in sufficient quantities. Accessibility, so this is access to all without discrimination. Acceptability, and this really entails acceptable and cultural appropriate and sufficient services. And then the last one is quality, which looks at meeting the necessary standards as we provide services. The next. So how does this now mirror into the global health diplomacy implications? We have national interests. All our countries are sovereign states, but we need to navigate national interests versus global solidarity, and this cannot be overemphasized. We have to look at issues to do with financing. I think all will agree with me that we are in a very precarious situation at the moment when it comes to especially official development assistance to our countries. These have markedly reduced. So how do we now look at health financing and then still ensuring that there's accountability for pandemic preparedness and response? Looking at the commitment to equity, I've mentioned the right to health frameworks that have been appended to already. So how do we now navigate our commitments to equity and still have ourselves prepared for epidemics and pandemics and continue to navigate the national interests? Then looking at our systems and the workforce resilience. How do we now, again, speak to what we have said we would do within the different agreements, but still ensure that our systems are able to withstand any shocks that may come to our countries and the region, and even our workforce, making sure that our workforce is planned to in such a way that they're able to respond to any shocks that may come to the system. So as EXA, we're standing by you to make sure that you navigate these different positions, and that when a situation comes forward, we're able to still be able to respond adequately. Next slide. So regional implications, we do have a high disease burden within our region. Our region is very vulnerable to different diseases, and these are not just nationally, but also the cross-border diseases and risks. And there's also a need for external investment in health systems. We do have some of the partners here who are willing to support us in making sure that we invest in the right way that is going to be responsive to the different epidemics or pandemics. And there's definitely importance for regional coordination across our countries. I'll give an example. The next slide will show you the readiness or the Global Preparedness Index currently. The world preparedness is the furthest to your right. That's the world preparedness. And Africa is to your left. So you can see that even with the world preparedness, Africa is really way below the preparedness. When we look at the Americas, which is next to Africa, Europe, even Southeast Asia, they're way above Africa. But Africa falls way below even the world preparedness. So there's more that we need to do together collectively to make sure that we go beyond what we're expected to be, and even the world preparedness as well. So some of the questions, next slide, I want to leave you with before I sit down as we have these conversations are our interests as Africa reflected in current negotiations? So when Ambassador Vuyile comes to the podium to share his experiences in the negotiations, please listen to what he has to say and also bring out if our interests are really reflected in the current negotiations. The second one is to look at our priorities. What are our priorities as Africa? And what are the red lines? Where do we draw the line? So we have our priorities, and then where do we draw the line as Africa in whatever is being presented? And then how do we leverage right to health? All countries, most countries globally have signed to the right to health. How do we leverage this right to health in our negotiations? And the last but not the least is, what capacities do we need? Do we need capacity in negotiation skills? Do we need capacity in responding to preparedness? Do we need capacity in ensuring that our systems are able to respond to the shocks that are presented to them? So with that, I would like to ask that as we move forward, next slide please, let's go back, review the texts and develop responsive regional positions. Let's align our national and regional delegations. So as we go to these negotiations, let's align our delegations that go to represent us to the priorities that we have as a nation, as well as the priorities that are being shared within these frameworks. And then let's continue to engage in multi-sectoral teams for negotiation support. Thank you. That's the last of my slides.
Thank you very much, Dr. Chisenga, for the presentation. Really very insightful in terms of our expectations and some of the questions that we need to prepare as we have the various facilitators presenting. So before we proceed to the first plenary, I saw a number of people going to the tea station, trying to check if the tea was ready. Just to announce that tea is ready. We're going to take a 10 minutes break. So you just grab your tea and then get back. After 10 minutes, we're going to continue with our first plenary. Thank you very much. Good morning once again. Just to announce that the conveniences, when you come out of this door, you turn to your left, then turn to your further left. They are somewhere around here. That's where the gents and the ladies are. Thank you. Good morning. I'll invite you all to settle down as we continue with the sessions. once more. We'll continue with our meeting. I'll now invite the moderator of the next sessions that we're going to have for the rest of the morning and the afternoon. Just to introduce the moderator, Connie, Dr. Constance Georgina Kaedi is a global public health specialist with considerable experience in antimicrobial resistance, primary health care, universal health coverage, health rights and equity, and development. She is the executive director of TALK ABR and a member of the steering committee of the Regional Network on Equity in Health in East and Southern Africa. Connie is also a member of the executive committee at the International Society for Infectious Diseases, where she also leads the Emerging Leaders in International Infectious Diseases program. She has been appointed to the World Health Organization Working Group on Equity and AMR. Connie is also part of the European and Developing Countries Clinical Trials Partnership, Stakeholders Group, and a thematic expert for SDGs Goals number 1, 3, 5, and 13 for the UN Global Partnership for SDGs, Legal and Economic Empowerment Global Network. She is a founding member of the REACT Africa and has been involved in the development and domestication of the WHO Global Action Plan on antimicrobial resistance across the region and its ongoing review and revision with greater focus on promoting equity as a means of addressing the socio-economic, geopolitical, and commercial determinants of health that make some of the communities even more vulnerable to AMR. Connie has authored, co-authored, and contributed to numerous studies and publications, including the soon-to-be-launched Aware QI dashboard tool that automatically generates quality indicator results based on the WHO Aware system, using existing point prevalence survey data to provide disease-specific insights to help hospitals guide clinical and policy decision-making for antimicrobial stewardship actions. Connie is also a mentor to many, including young leaders interested in STEM and climate justice for the HAL Lab and Global Give Back Cycle and the MasterCard and Tony Elumelo Foundations. A warm welcome for Connie as she comes to moderate the upcoming session.
Thank you so much, Dr. Langwa, and good morning to you all. My name is Connie, and I will be moderating plenary number 1, the Pandemic Agreement and Revised International Health Regulations 2025, and the implications for Africa. During this session, we will look at reflections from the negotiation process and World Health Assembly 2025, the African positions, and resolved issues for negotiation and areas for implementation. We'll also look at strengthening equity, preparedness, and global solidarity. After that, we'll have an open session of questions and answers and interactive discussion. This morning, as part of our plenary session, we have Ambassador Boyile Dlamini, African representative in the Bureau of PABS negotiations, and Dr. Charles Fourier Jukuna, Regional Advisor for Country Readiness Strengthening at PABS. To give us the first Charles Fourier Jukuna, we'll talk about the pandemic agreement and revised international health. Dr. Jukuna is a seasoned public health with over 30 years of experience in clinical medicine, public health, epidemiology, and leadership. Dr. Njuguna is currently serving as Regional Advisor for Country Readiness Strengthening at WHO going person. He has held pivotal roles in Kenya, Sierra Leone, Uganda, and the regional office for over 20 years. He also recently served as an acting WHO country representative to Uganda. Dr. Njuguna has served as WHO incident manager for multiple public health emergencies of international concern, including Ebola and COVID-19. He is recognized widely as one of the fathers of integrated disease surveillance and response, and has also played a very pivotal role in advancing international health regulations. Please help me in welcoming Dr. Njuguna. You might take it.
Thank you very much, moderator. Good morning once again. Good morning once again. Yeah, I would want us to be together. I don't want to talk to myself here. So I want us to be together. I will try to provide a quick overview on the process of the amendments of international health regulations, and also I'll have some few other slides on the process of the pandemic agreement process. Then after that, the ambassador Lamini will come and also speak to those issues. I don't know where we are, but I know we are not at the same level when it comes to these issues. And the purpose of this engagement is to try to help all of us to please quickly try to bring us up to speed and have some level of understanding on these very important two processes that have led to these instruments. Therefore, I don't want to assume that we are at the same level. So I'll try as much as possible to explain what I can manage. But again, my boss was the one who was supposed to do it. He was not able to come, but I believe I'll do the justice. So let's first of all try to look at international health regulations. Okay, next slide. Yeah. I wish there was a mobile, the loose mic. I was once a teacher, so the element of being boxed in one place causes me to be a bit feeling restricted a lot. Yeah. I used to be a teacher a long time ago. Yes. I think this is better so that I can flex a little bit. So, ladies and gentlemen, international health regulations, that document you are seeing there has come a long way. And of course, soon we expect a new version to be printed. But this is a legally binding instrument that has 196 state parties. Why do we talk about state parties and not member states when we come to IHR? It's because not all the signatories are countries. Some of the signatories are not countries, like Vatican. So Vatican is a state. So they are signatory to this, the Holy See, and another one. So that's why, to use one common language, we talk about state parties and not member states. I hope that is clear. So the state parties, the 194 has already been their signatories, and there's an instrument that has had a long journey to come where we are. It started many years ago. Around 1951, that's when we had the first one. It was called International Sanitary Regulation. By 1969, it was revised. We had a second edition, which was also amended in 1973 and 1981. Then there was also a revision in 1995 to 2005 that led to the third edition. So the World Health Assembly in 2005 enacted the IHR. That's why it's called IHR 2005. But it came into force 2 years down the line in 2007. So we call it IHR 2005 because that is when it was enacted. Now, when we had these challenges of Ebola in West Africa, we had the H1N1 2009, then there was need to review these regulations in 2014 and 2022. But the whole scope of the international health regulations is to prevent, protect against, control, and provide a public health response to the international spread of diseases in ways that are commensurate with and are restricted to public health risks and which avoid unnecessary interference with the international traffic. I told you in the other meeting, for those who are there, that infectious diseases can spread at a speed of a jetliner. It just takes one person to board an aircraft and introduce that infection in another continent. As a matter of fact, today, you can reach any part of the world within 36 hours. That's how serious it is. We are a global village. So that's why we say a threat in one place is a threat everywhere. Next slide. Okay, so this is the process. Now, after the 22 amendments, now we had to do the amendments of 2024. Why? Because again, the pandemic emergence. We had a pandemic emergence. IHR, the highest level of emergence was what we call FIC. FIC is Public Health Emergence of International Concern. That was the highest level. If the Director General would declare FIC, then that is the highest level. But as much as he declared COVID-19 as a FIC, to so many countries, it didn't resonate very strongly with them because there was no use of what? The word pandemic. So, and because the world knows more now about pandemic, and once you mention pandemic, they take it more serious. So there was a need to now to revise this instrument. Let's move on. So the whole IHR 2005 has 10 parts, 66 articles, and 9 annexes. We'll not go to the details. I'm just trying to help us just to have a general overview of these regulations. So this is what is contained. Let's go to the next slide. Now, the process of reviewing now what we call the 2024 amendments. Again, it was informed by the lessons learned from COVID-19. There were serious gaps and inequalities in the whole response. There are many countries that were left, in terms of the queue of accessing those medical products. So it was a very difficult time. And now the issue of global solidarity was being on the table, people talking about global solidarity. But there are nations that, for them, we protect our people first. Would even rather procure vaccines for the whole population for first, second dose and have it. But at the same time, another country does not even have few doses to cover people who have comorbidities and people who are elderly, who, if they got COVID, then they would have most likely the bad outcomes. So there was an independent process of reviewing, and over 300 recommendations were given to the Director General. So what do you do with over 300 recommendations? Then that is what now, out of that independent panel that came up with over 300 recommendations, there was a member state working group. And remember, governments, member states here, these are governments, that head up, that looked at all this and came up with a report. And that report is what now led to the establishment of the Intergovernmental Negotiation Body, the INB, that was approved or enacted in the 2021 special session in December. Then also the WHO of 2022 came up with a working group for international health regulations. So look at it this way. We have this serious problem we need to address. We already had existing IHR here, which has been found to be deficient. And then there are serious gaps that needs to be addressed that cannot even be accommodated in an IHR. Then you need an accord or an agreement or something that can be legally binding. So that's why now the two processes had to go parallel. One process is reviewing the IHR 2005, and the other one is now coming up with a pandemic agreement. Let's move on. I'll move to the next. So, when the experts looked at this IHR, there was 307 proposed amendments. For, it has 66 articles. So 33 of them to be revised. Then 6 out of 9 annexes to be revised. And also ensure there are new articles, 6 of them, and 2 annexes. Let's move on. This one you don't have to mind. It's just all the details about those amendments. Move on. So this is a process that I've talked about. Move on. Now, let's look at the key elements. In the IHR, one of the new things that has come up is now the need to establish the National IHR Authority. That is a new thing. And all of us need to hear that, because as member states, this is very important because you are the ones who are supposed to implement. Initially, in IHR mechanism, we had only what we used to call IHR NFP. IHR National Focal Point. And the focal point, NFP was supposed to be a center that has the capacity to run 24 hours in terms of communication, in terms of coordination. But how they are established in different member states, not the same. Some countries are better than others. Others will have one man or one woman who would say, I'm the NFP. But yet it was supposed to be a what? A center. Now, why has the National IHR Authority been established? That authority, once you establish it within your country, because you're the one to do it, it is supposed to oversee the implementation of IHR, the amended IHR that has been agreed upon. So the authority is supposed to focus on implementation of those articles. You are supposed to ensure they are domesticated. Some of the countries, you already have laws that accommodate IHR, but not all of them. You need some people who have legal minds. And if you're blessed enough to have somebody who has a background in public health and is a legal expert, there are few of them. They would help you now to look at all the existing instruments and see whether those instruments allow for the implementation of the amended IHR and also the pandemic agreement. So that's a process as member states you're supposed to undertake. So the other thing, it has accommodated the issue of pandemic emergency. When do you declare pandemic emergency? 4 things are now going to guide that declaration. 4 things. Anytime you have a public health emergency that has the risk of spreading widely, many countries across continents, that's one of the criteria. The second criteria is about the national health systems. Is that public health emergency likely to overwhelm the existing health systems in a country? If yes, then it becomes of great concern. Your systems may not be able to contain it, and it has a risk of spreading internationally. The third thing about the pandemic emergency is about, is it likely now to cause serious socio-economic disruptions, like the way we have seen the pandemic doing? So if that is the case, it becomes a third element. And the fourth element is that it's going to provide now, that emergence also requires a coordinated, an enhanced coordinated international mechanism of responding. Because the policy, the approach of IHR is to ensure you contain at the source. So those 4 things is what are used to declare a pandemic emergency. So, but there are some areas we have to discuss, and I believe the ambassador will reinforce on some of these issues, especially about the pubs. We'll come back to that. And the coordinating financial mechanism. Very important things. How do we look at those things? Many countries in our region, anytime there's an emergency, they don't have ready money to move. Is that a reality? Yes. So, but how do we now ensure we have systems that are agile, they are able to work well? So these are the issues. So let's move to the next slide. I don't want to deep dive in this. Move to the next one. Okay, now, this one I'll just make one statement. This was done before, and that process we have gone through it. Eventually in 2024, the amendments were agreed upon. And now, they were given a period of when to come into force. Once resolutions are adopted in the World Health Assembly by the member states, the state parties, then there must be a time frame when they are supposed to take effect. Friends, when did the new amended regulations come into force? I told you the 2005 came into force in 2007. What about these ones that were passed in 2024? When did they come into effect? Or when did they enter into force? I told you I was a teacher. So I would need to hear from you. Who can tell us when it came into force? The peers. Now look at how things are happening. Peers, they are pushing the ball to you. Really? Okay. They came into force in September 2025. So what does that mean? Because you are signatories to these regulations, and they have already come into force and you don't know. So you need to look at them and see what is supposed to be done. It's a responsibility of each member state. Like now you are supposed to look at them because you are supposed to establish a national IHR authority. And there are other things you are supposed to do. And now also the pandemic agreement is there. So let's move to the next slide. So let me stop here. Let's go to the few slides on the pandemic agreement. Then I will allow the ambassador to continue. Please, But I hope the presentation is making sense. Huh? Hello? My brother, you are okay? You are learning. I see you are taking serious notes. Burundi is going to transform things very fast. The way he's taking the notes in a very methodical way. And he's a big man in the ministry. You can be assured. Burundi, we are done. Yes, now, again, just an overview on the pandemic agreement. Let's move. Now, this agreement is guided by equity and the principles of sovereign rights of states. So there are a lot of propaganda that WHO has an agreement that they are going to be forcing member states or state parties to do certain things. That's a big lie. In fact, these agreements, the process has been led by government. Not, WHO is a secretariat. Where are you a secretariat? So those misinformations that are out there, WHO does not really infringe on your sovereignty. So there's full respect for the dignity, human right, and fundamental freedoms in the pandemic agreement. Full respect for international humanitarian law, equity as goal, principle, and outcome. Solidarity, this big name solidarity, with all people and countries. When I was making the opening remarks, I talked about the issue of nationalism versus what? Was I talking to myself? Versus what? Multilateral. So when you talk about multilateral processes, is that we are coming together with that spirit of solidarity, and we are sharing these goals and aspirations. But if we go on our own, then that becomes nationalism. So there are issues we can pursue the nationalism. There are issues we can pursue bilateralism, but there are issues that we need multilateral systems. And now for these two instruments, they become more powerful when there is solidarity, when we agree together. So it is also seeking to ensure that the best available science and evidence is used. And all this is about to prevent, prepare, and to respond to pandemics. We do not know when the next pandemic will happen. But for real, can we say that there will be no other pandemic? No. That's why you have heard people talking about disease X, trying to define the next pandemic as a disease X. Because when you look at today, about 75% of the emerging and re-emerging infectious diseases, they are zoonotic in nature. And because there is a lot of interaction in the ecosystem between human, animal, and the environment, those interactions definitely, they don't leave us the same. We are likely to have spillovers from the animals, from the environment to human populations. Let's move to the next slide. So, the pandemic, the WHO pandemic agreement was adopted in World Health Assembly 78. When you hear adopted, then you cannot make changes. When you hear adapted, you can make changes to your context. That's the difference between those terminologies. Adapt, adopt. So this agreement is adopted by the World Health Assembly. So you cannot go with it to your country and say now we shall do cherry picking and decide to make changes here and there. No, it's already agreed upon. Let's move on. So it has been a long process of the INB, which I'm not better qualified to talk about it than the ambassador. So the ambassador should talk about this more. But it has been a process that after 13 meetings, a lot of work, we eventually had this instrument that was presented as a draft and it was adopted. Let's move to the next slide. So, that pandemic agreement again, how many of you have seen it? Just raise up your hand. I'm doing surveillance. So I'm seeing like 4 people are the ones who have seen it. It's available in the WHO website. Make effort to download it because your country is going to be expected at one point to sign. So please download it, look at it. It has about, is it 35 articles? You can confirm, Ambassador, if my mind does not fail me. 35, so I'm correct. 35 articles. And go through those articles. And more importantly, Ambassador will tell you, Article 12, let me leave it to him. You'll come to handle the hot potato. So, this, and you remember, in these negotiation processes, there are things people agree, but there are things people don't agree. People have different positions. So that's why you have to negotiate. That's why you need global health diplomacy. Yeah? DGX, this is when you need now this. Yeah? Diplomacy. To be able to negotiate in the global space. But we need to be one as Africa as we are negotiating. Are we together? So I'll not go to the details. Let's go to the next, because I'm trying to see how to leave the hard things to the ambassador. Yeah? So basically, we have an open-ended working group. That's a good thing about it, that this working group will continue working. Although we have now the agreement, but because there are issues to be done, there's an annex that is based on Article 12.2 to be done, the PABs, the pathogen access and benefit sharing. I don't want to talk much about it. Yeah? So, those are the things. Let's move on. That PABs is there. Next. I just wanted to say thank you so that the ambassador will come. Otherwise, I hope I've given you an overview that helps you to begin to understand the process before the ambassador, who has the gist of the matter, comes to the floor. Thank you very much.
Thank you so much, Dr. Njuguna. Thank you for that very clear explanation of the international health regulations and also the necessary revisions and the need for those amendments, and also pulling in the pandemic agreement and how they complement and work each other, and how they complement and support each other, sorry. And now to add weight into that discussion, I would like to call Ambassador Dlamini. Ambassador Dlamini is the permanent representative of the Kingdom of Eswatini to the United Nations and other international organizations in Geneva. He is a professional. During his professional career, he has worked in several governmental sectors, such as the Ministry of Justice and Constitutional Affairs, the Ministry of Health, the Ministry of Foreign Affairs and International Cooperation, including in national and international offices. Ambassador Dlamini has participated as a member of the Kingdom's delegation at numerous regional and international conferences and workshops on international and multilateral actions on human rights, and presented numerous working papers, and delivered several addresses on behalf of the Kingdom at some of these conferences. He has served as a member of the Kingdom's delegation at high-level meetings of regional organizations and international organizations such as the General Assembly of the UN Human Rights Council. Ambassador Dlamini currently serves as one of the vice chairpersons in the Bureau of Intergovernmental Working Group that is negotiating the Pathogen Access and Benefit Sharing Annex, PABS Annex, to the WHO Agreement on Pandemic Prevention, Preparedness, and Response, or generally the Pandemic Agreement, and is also an advisor to the expert group on Article 19 of the WHO Framework on Convention and Tobacco Control. I would like to welcome Ambassador Dlamini to give a talk on leveraging the Pandemic Agreement, revised international health regulations, and the right to health to advance Africa's global health diplomacy agenda. Welcome, Ambassador.
Thank you very much, Connie, for the introduction. And as I walk to the podium, I'm not too sure if this is the podium or the pulpit, whatever name you want to call it. Thank you for the introduction, most kindly. And thank you, Dr. Charles, for setting the scene, and also all those who spoke before me. By training, I'm an attorney, and I like to talk and engage, and we must have an interactive dialogue. Before I go to the slides, I see the PS has duly left the hall, and may I recognize those who were sitting in the high-level table, recognize all the colleagues who are here, the principal secretaries, and also to say how happy I am to be here, not because I'm in Lusaka, but because I'm going to be engaging with you colleagues. Let's engage in an interactive dialogue on these issues. You see, when you look at the workshop that we're in here, is talking to global health diplomacy, and then with the theme leveraging the pandemic agreement, revised IHR of 2005, and the right to health to advance Africa's global health diplomacy. If I may ask, or maybe kindly allow me to ask this question, especially to our principal secretaries. What is your understanding of global health diplomacy? You are attending a workshop. What does this workshop mean to you? What does it bring to mind immediately to be saying, look, I'm going to a workshop on global health diplomacy. What does it entail, or what does it involve? Those are the questions that we will have to dissect when we go to the question and answer session. I've already prepared you on that. And then there are also issues that resonate very well in terms of the background information that my brother, Dr. Charles, has just brought in. We're talking into these two instruments, the International Health Regulations of 2005 as amended. They are revised, and they came into force in September of this year. And then you have the WHO Pandemic Agreement. In short, you call it the WHO Pandemic Agreement, but it's the WHO Pandemic Agreement on pandemic prevention, preparedness, and response. It addresses the three P's. Pandemic is PPR, pandemic prevention, preparedness, and response. These two instruments, the question that you need to ask yourself, why are they important for public health? And what do they mean to our individual countries, or even the region of Africa as a whole? These are the questions that you should be battling with as well. And then also, just to buttress the point, Dr. Charles, these negotiations, the working group on the IHR and the Intergovernmental Negotiating Board, they were happening at the same time. You can then imagine how difficult it is to balance, to find a balance in the negotiations of both international instruments. So you should then applaud your resident diplomats in Geneva for a work well done. Also, it calls upon us as members of the region of Africa to ensure that we prepare for the negotiations. We are ready and we know what are the set priorities for our region. I've been told in diplomacy that when you think internationally or globally, but when you implement nationally. What overrides your national interests is the global thinking. You think and then you come back and then align yourself with what we have agreed on at the international level. That is how it works. So again, it's that kind of thinking that we need to have. Also, I would like you to kindly allow me to take off my glasses, because why? I'm long-sighted. I cannot see far, but I can see here. So the glasses are meant for me to read something that is very far. But when I read something that is very close, it becomes a little bit blur. Those who are wearing glasses will want to understand that better. And even I take it that most of you are medical people. You understand these issues. So most kindly, I will take off my glasses as I read through the script. I've prepared a few questions again before I go to my slides. I think there is an issue that I want to bring it on the table again. It's an issue that I think most of the representatives that spoke before me talk into, that relates to how do we ensure that when going to international negotiations, we know the interests at play. We also know the priorities of the region. Dr. Charles talked about Africa being last on the queue. And that's reality. The reality is that for us as the region of Africa, we received vaccines very late, and we were meant to wait for long periods of time. Why is that the reason? It's because one will say we couldn't produce the vaccines ourselves. So that talks to issues of regional production. We didn't have the infrastructure in place. We didn't have the capacity to do so. So what is it that we need to do? I'm sorry, flat. But can you still hear me? Okay. So these are the issues. Now I will kindly ask that maybe we start looking at the slides. You jump slide 1. You already know me. It was a moment of great happiness when we adopted the pandemic agreement, of course. Because it was at a time when we thought, because we already know that the world is so polarized, it's not easy to come to an agreement. I recall Dr. Charles, in 2 sessions, just before the close of the negotiations, we were negotiating until the morning of the following day. Very tough to come to agreements. We first stopped at 9:30 in the morning. We couldn't agree. It was supposed to be the last day of the negotiations. Then we extended for another day, for the following week, in fact. It was another day, but for the following week. Again, the agreement was agreed around, the agreement was reached around 10:30 in the morning, having been negotiating the whole night, the whole day and night. So that's how tough it is. So that calls for you as the principal secretaries and leaders of the region of Africa. One, to ensure that you take charge of these matters. How you take charge? You bring your experts to the negotiation table. You bring people who already know that the stakes are very high, and also people who will be dedicated. I will tell you that negotiations are not a panacea. They require a lot of discipline, dedication, goodwill, good faith, and a lot of trust. You should be able to anticipate what the other side is going to be saying and be ready to compromise, but without giving up on the core principles or the priorities that you need. You must also have your own red lines, because it's a question of compromise. But there must be no hidden red lines. Why? Because it is very difficult to navigate around them. So good faith is very important when it comes to negotiations. I will say also, when you talk into the issue about foreign policy and health, these two things must speak to one another. Why am I saying that? I will go to my fellow countrymen. Why is foreign policy and health should be speaking together? What will be your responses, Busiso? I'm not putting you on the spot, but it's because I know you know the answer. You're still thinking about it. Yeah? In health negotiations, we need to see health as a goal for foreign policy. And foreign policy must promote the health of all people without discrimination. This is that understanding. For instance, you need to understand that health and foreign policy must work together to bring, for instance, medicines to the people. And that requires us to put health highest on the development agenda. I will say, for me, this is what is important when you negotiate around issues of public health. You need to have that common understanding. And I was once told that I was asked to say, what is my understanding of public health? I'll tell you my understanding. It's my own understanding of what public health entails. Public health to me is the common pathway to human endeavor, so that if everything else fails, be it in transport, education, anywhere, it becomes a public health problem. That's my understanding of public health. I'm not an advocate of that, but this is what I think it is. Nelson Mandela once told us that it seems impossible until it's done. We're able to negotiate and agree on the pandemic agreement. But the pandemic agreement was adopted, as Dr. Charles has said. Then what happens after adoption? Do the PSs know what are the next steps after adoption? I will tell you. The agreement has to open for signature for a certain period of time. Once a number of signatures have been obtained, and then the ratification process sets in. After ratification, then again, with a certain number of ratifications, then the agreement comes into force. So for the pandemic agreement, it was agreed by the Health Assembly that we're adopting it, but we're putting it on hold until the pathogen access and benefit sharing system is agreed, adopted as such. Then with that, we are being told, and this is what we all know, that the process when it comes to negotiating the pathogen access and benefit sharing system, it's a process that is very necessary because it is the centerpiece, or if you like, the heartbeat of the pandemic agreement. The pandemic agreement won't even start to work without the annex. So it is very important, again, that we engage in that kind of argument in terms of why the pathogen access and benefit sharing system, as mandated by Article 12 of the WHO pandemic agreement, that we are saying in Article 12.2 that the system is hereby established, but its modalities and other issues are going to be negotiated, and they will appear in an annex. So this is where we are. Question is, what are the core principles of the agreement, of the WHO pandemic agreement itself? You will say they are access and equity. They want to address those issues, basically. Access and equity, because you recognize that our countries, they vary, widely in capacities and to prevent and manage pandemics. And that these disparities often translate into delayed or even insufficient responses, in fact, in lower income settings. So that is the recognition. We come from there. And then to address that, then you want to then talk into the issue about the pathogen access and benefit sharing system, which ensures that the sharing of biological samples and data, is matched by the fair and timely, not only fair and timely access to the resulting health technologies. You talk about VTDs, you talk about technology transfer and all. So this is where but I will be talking to that at a later stage. So we celebrated the pandemic agreement with that aim, to be saying that it's a framework to strengthen collective preparedness for and response to future pandemics. Can I go to the next slide? The agreement outlines overarching commitments of countries, to pandemic prevention, preparedness, and response. It mandates for the development of a pathogen access and benefit sharing system as a critical annex to ensure equitable access to medical countermeasures and timely sharing of pathogens. I've already spoken to that. I'm not too sure if we are going to overload with you in terms of understanding the PA itself. And then Dr. Charles talked to the issue about the open-ended intergovernmental working group, for which I represent the region of Africa in the bureau of this process. Now, the thing is, I'm no longer negotiating, but I'm there to assist, facilitate the negotiations. In the past, I was participating, and I think, if I recall very well, without petting anything, most of the ambassadors in Geneva, they don't do that because they are the bosses in the missions. The reason why I had to do that is because for us, we are a small delegation, and only one colleague is responsible for the health file. So then I took it upon myself, considering that I have the legal background and also I've been working in the ministry. I understand the issues a little bit, of course, not to say I understand all and also looking at the amount of work that was involved. You are negotiating two international instruments at the same time, which requires you to be disciplined, dedicated, and also have the resolve to be saying, look, this is what we want for our region. And also we have also your own national interests. But the PSs, I want to challenge you here. The challenge that I want to put in place, these issues were brought to the table when we were discussing earlier on the presentation before. The health diplomats in Geneva, I want to say this so that you understand, they are overwhelmed. That work there is just too much for a single person in a mission to handle. So it's very important then that our capital colleagues are actually capacitated to come for the negotiations so that we buttress the points as a region. The good thing that I want to assure you is this. My experience with the negotiations, I've seen Africa. Africa has always been negotiating as one. You know, this is one good thing about our region, that we have never had a situation where, even if there are disagreements amongst ourselves, we try to actually close those gaps without even the other colleagues knowing what is happening in our group. So this is the good thing. But it is very important that you prepare the local colleagues, the capital colleagues must come. I want to commend a few countries, of course, that have done that, because it's very important that we talk about it. You know, there are countries in our region which will go to extremes to bringing highly technical people. They will have a delegation of 5 to 6 colleagues coming for the negotiations. And they do the exact thing that the developed countries are doing. Because what they do is they bring 10 people, but they interchange. You know, in the morning, it's one set of negotiators. In the afternoon, it's another set of negotiators. Then if it goes overboard, that you even negotiate through the night, it's another set of negotiators. So they refresh the colleagues as you negotiate. I think it's a good strategy so that you keep momentum and you widen, you know, the scope of understanding of the issues within your national context. It's a challenge to the peers that I'm bringing on the table, at least when it comes to the negotiations themselves. And then can we go to the next slide, please? Okay, we say the PAP system is critical to the implementation of the WHO pandemic agreement and the operationalization of equity, ensuring access to medical countermeasures, the timely sharing of pathogens with pandemic potential, because there's a scope. The scope has already been set in Article 12. Is pathogens with pandemic potential that the system is going to look at. And equally importantly, the sharing of benefits derived therefrom. It is the center of the pandemic agreement, is an integral component to ensure that equity is operationalized. And then in the agreement, it is the heartbeat or cornerstone of the agreement. Now, question is, do you agree with this statement? That is, it's the centerpiece. And if you do, what will be your understanding of that statement? And if you don't agree, why don't you agree? These are the questions that you'll be coming up in your mind as you go along with this. It is widely considered, and then why considered as the centerpiece? You may want to ask those questions, the colleagues, the PSs. And then my response, because I have my response to it, is that the PAPS is indeed the centerpiece of this agreement. And why do I say that? I will say that because sometimes my handwriting becomes a bit difficult to read. As an attorney, you write like a doctor sometimes. You know, it is crucial for ensuring global equity in pandemic prevention, preparedness, and response. You it is a vital component of the entire agreement to ensure that the agreement enters into force. So until the PAPS Annex is finalized, and indeed adopted, the agreement will remain but a dream. So it's a challenge again to be saying we need to note the importance of the annex or the process that we have engaged in negotiating the PAPS Annex. Can we go to the next slide, please? We want to reverse the inequities of the past. We spoke to it, Dr. Charles, by ensuring that the originating countries of biological materials derive the corresponding benefits arising from their sharing of the materials in monetary and non-monetary terms. In the agreement, we talk about 10% of real-time production and 20% voluntary. So you will go to that and then see how will that be implemented, Dr. Charles talked about the issue of the coming into force of the international health regulations as amended. And then he asked a question, how many of you know when does that happen? And then we gave the answer for you. And then the question is, immediately that happens, certain obligations kick in. There are expectations arising from the very instrument that we're talking about, that you individually and us collectively as a region, we need to then start steaming ahead and start talking about implementation. For those of you who are maybe legal persons, there's this thing about in Africa or even in the world altogether, treaty fatigue. Treaty fatigue. Most of you can't even tell me how many international agreements has our individual countries have signed and ratified. So it's a challenge within the ministries of health themselves that we should have these treaty departments. You look specifically in those treaties that touch on your department to be saying, where are we in terms of implementation? What is it that needs to be done? Countries, they talk about the coordinating mechanisms for actually following on implementation and stuff. But it is a big challenge for us. So we need to look at that as a matter of course. The priority for the PAP system that we envision must be the speed at which we respond to emergencies. And of course, future proofing, consistency, and comparability are very important components of the PAP system. So this is the system that we are establishing. In fact, it was established, but then we're now talking about the modalities of bringing it into life. Next slide, please. This I'm just saying because as we negotiate, it's important that we do not get ahead of ourselves. But we must appreciate that for the PAPS Annex to be long-lasting and effective, it must be inclusive and acceptable to all member states. It's a statement of fact that it should just do that so that it becomes effective. And then, what does this mean for the African region? For the African region, the PAPS Annex presents an opportunity to do the following: to address long-standing inequities in global health systems, to assert our sovereign rights over our biological resources, and to secure meaningful benefit sharing for contributions to global health security. Can we go ahead to the next slide? Therefore, a coordinated engagement among African member states will be critical to ensure that Africa's priorities are reflected in the final design of the PAPS system, particularly regarding timely access, technology transfer, capacity building, and the strengthening of regional manufacturing and surveillance systems. We're talking to all international health regulations. It has to resonate to that. Also, there is a need for the African region to continue to ensure that we approach the negotiations with a unified voice. And we count on the support of our leaders for that to happen. You, the principal secretaries, you have that responsibility, to ensure that that does happen. These we need to do to ensure a safer, healthier, and prosperous Africa in which member states are prepared to timely prevent, detect, respond, and effectively respond to public health threats and outbreaks. It is for the public good. When you do something for the public good, God will bless you, of course. Because it is not about you. It is about future generations. It's not a personal issue. Okay. Differences among member states. As we negotiate, we appreciate that there shall be differences. Where the members remain distant apart, I've highlighted from each other in terms of approach and entrenched positions, notwithstanding the already agreed, because they are already agreed parameters within Article 12 of the PA. But you will be surprised when we negotiate that you find when you talk equity, it becomes taboo to some of the colleagues in the room. They have a different understanding. When you talk about access, the region of Africa will tell you what we say in terms of access. For us, there's simply, when you talk access must be on agreed terms. Access to the pathogens. There's nothing like free riding. We want to avoid issues of biopiracy. For the longest time, our region has been actually robbed of our pathogens. They get them, but when it comes to what has been developed following from that analysis, we're the last ones to get anything, if at all. So this is what we're saying here. Such issues include, but are not limited to, the very same alternative access and benefit sharing system that is envisioned by Article 12. When we talk about that, people are starting to be saying, no, this is not possible. But we've already agreed. And then how same resonates with the already existing access and benefit sharing systems, like the ones obtaining under the Convention on Biological Diversity and in its Nagoya Protocol, including the Plant Treaty and the BBJ-NJ Agreement and existing domestic ABS systems. You need to understand that and find that balance as well. Other thorny issues include complexity of digital sequence information, and questions relating to what is being shared, with whom, how, and when. Very critical issues that come up. The issue of legal certainty and traceability, and the whole concept of the link, if any, with traditional knowledge associated with genetic resources. We might want to have a conversation of that. And I want to assure you, Principal Secretaries, that in the region of Africa, we have highly resourced personnel when it comes to these issues that relate to traditional knowledge with genetic resources, the linkage. We have colleagues, especially from the land of the brave, which is the Republic of Namibia. They have colleagues from the Republic of Kenya. We have colleagues all over the region of Africa. They are highly knowledgeable. And we count on them, and we count on you to ensure that you persuade the colleagues to come to the table and negotiate with us. However, member states continue to note and underscore the fundamental point about changing the status quo. We all want to change the status quo. And looking at the bigger picture of reversing the iniquities of the past and achieving the bigger goal of health for all and global health security and solidarity. Big terms, like you said, Dr. Charles. How do we achieve that? Those are the questions. One key demand of developing countries generally is for adequate traceability and transparency measures to provide clarity on the providers and recipients of the PAPS materials, drawing inspiration from the PIP framework. The PIP framework on the influenza, which has the influenza virus tracking mechanism that provides information on materials shared with and outside the WHO Global Influenza Surveillance and Response System, the so-called GISRIS. Participating manufacturers must grant non-exclusive licenses to developing country manufacturers, as well as real-time allocation of VTDs, as vaccines, therapeutics, and diagnostics to affected countries during a fake, a public health emergency of international concern, to ensure access to these VTDs and to scale up production and expand supply options. It's very critical that we do that. And then fundamentally, these are my concluding advice and remarks. The system we are establishing must be trustworthy and function to advance global health security. The African region must continue to support open collaboration, but we must keep benefits and safety attached to the science. The only sharing that will help our region is one that will have meaningful impact in reversing the status quo and resulting in clear benefits for the region. It will be important, therefore, that we continue to advocate for a pathogen access and benefit sharing system that will guarantee full access to the samples for the manufacturers, but same must be on agreed terms. This is what we're saying. There could be no access without agreeing to that. And the provider of the supplies, samples, must receive equitable benefit sharing. This is all about it. It's about equity. We share and we receive benefits for the sharing. We need to continue to stress the point that for the African region, equity must be operational, enforceable, and measurable. We need to call for clear legal triggers for benefit sharing at both fake and pandemic times, with real-time product allocation and agreed technology transfer. We need to stress that the PAPS Annex must contribute to building Africa's efforts to strengthen research capacity for regional manufacturing to ensure regional safe self-reliance. I want to end to say that while the IGWIC process is inevitably navigating political aspects of negotiating a pathogen access and benefit annex, public health must continue to guide all of our discussions and approaches in pandemic prevention and in pandemic PPR. The end goal is to protect humanity from existential threats to the health of billions of our people, to shape a framework that will help to make the world safer when the next pandemic strikes, and for which solidarity remains our best immunity. Thank you for your kind attention.
Thank you so much, Ambassador, for that very insightful presentation. You have touched on a lot of really important issues. Can you hear me now? Great. Thank you so much, Ambassador, for that really insightful presentation. You have touched on a lot of really important issues and concerns, vaccine access, local production, thinking globally and acting locally. You've talked about the fundamentals of negotiation and how the global health diplomacy process fits into all that. And you've also talked about the need to look at health policy as foreign policy and a process of, using it to promote health for all. And you've also touched on pubs and how important it is for pandemic agreement and it being the heart of the process, and also the need to ensure that that is progressed effectively. And you've also recognized that the singular African voice and the need for that to continue at these global platforms, and also recognizing the need to build local capacity as well. So thank you. Thank you so much for those very important highlights. Now we're going to open the floor to an interactive discussion and Q&A process. But first of all, I'd like to ask Ambassador Dlamini and Dr. Njuguna to please come to the podium. Thank you.
I'm suggesting, if you agree as a panel, because of time, we could merge with the next panel because he has already talked quite a lot about Africa and the way forward. Ambassador, you can still sit. I could add few things, which was in the second panel. Then we just have like one discussion and finish the two panels. Does it make sense? Hello, does it make sense? I know that your sugar levels are going down, but you have to talk, huh? Yes. So I'll do a few things here. And actually, Ambassador, you have made the next panel, the next panel which was supposed to discuss about Africa, the way forward. You have already handled much of that. And I think I'll just maybe mention a few things. Then because I was supposed to handle the next panel, then we will be done. And my colleague, Dr. Sohel, who is from HQ, I'll also give him a chance just to say a few things, then we do Q&A, we finished. Excellent. So I told you Ambassador will come and deal with issues, and he has done it. Have we appreciated him? Huh? Okay, he has done a good job. Thank you very much. Now, there is something he has said, which I'm not sure whether we have understood what he has said in regarding ratification. Did you get to understand about now the ratification of the pandemic agreement, how it will happen? Did you get to understand what he said? Anybody who got it? Please, just tell us what he said about ratification.
I think he said that at the moment, the agreement will be opened for countries to sign.
Yes.
And it's from the way he explained, it's like they'll just look at if the majority have already signed, not everyone, but the majority, that's how I got it.
Yes.
It will move on to ratification. Again, they will look at whether the majority would have signed. That's how I got it.
Thank you, thank you, thank you. There is no wrong answer here. Thank you for that response. Somebody else? What did you understand the ratification? You know, he's a lawyer. The ambassador is a lawyer. He talked his legal language. But let's bring it home for other people now. Did you understand? Ratification is, he is talking about when the pandemic agreement will come into force. It's already adopted, but it's not yet in force. So how will it come into force, what he was calling ratification? Somebody else? Because these are the most important things you need to take away. Yes, sir.
Yeah, since there is no wrong answer, I might as well speak.
Yes.
Yeah. So I think he talked about having an annex on how we need to agree on the PABS. Then if you have that annex, then we can agree on how we operationalize. And that is central to the pandemic agreement.
Very good. He has now brought the aspect of annex on the PABS. That's an addition. Somebody else want to tie all these pieces together? Yes, sir. This is Kenya. And you need to know, now that you are here, that discussion was in State House yesterday in Kenya.
Yeah, so on the issue of ratification, I think so countries will be required to deposit the legal instruments with their legislature, so that it can only be considered to have been ratified by a country when those legal documents are produced to accompany the agreement.
That is now an addition from Kenya. Now, let us now tie it together. What our ambassador has told us here is that as much as the pandemic agreement has been adopted, it remains in text. It can be an aspiration if we don't do what we are supposed to do. Because it is not legally binding. Although it's adopted, but it's not what? Legally binding. When will it become legally binding? Is until he has emphasized annex that goes, annex that is speaking to Article 12.2. That as member states, you are supposed to ratify. There's no shortcut about it. Every member state is supposed to do what? Ratify. Already, the working group met the other day to look at that PABs. There is already a draft. There is already a draft. I've seen it with my eyes today. There is already a draft. And already that process has started because in the next World Health Assembly, the working group is supposed to present, the INB is supposed to present it, isn't it? So that it can also be adopted from there in the World Health Assembly. Next World Health Assembly in May 2026. Once it's adopted there, it has to be domesticated. Every country needs to ratify it. And that will require your legal processes, maybe going through parliament or whatever. So the moment Burundi ratifies, they deposit the instrument. DRC ratifies, they deposit. Which country, my brother? Oh, okay. DRC is very big, so they have to have 2 slots. So DRC, Ethiopia, Kenya, Lesotho, yeah? From the high altitude there, you must do it. Malawi, Mauritius. And how many countries do you need to ratify to deposit the ratified? How many? Minimum? 60. That is the threshold. Yes. 60. So look at it this way, my friends. If we don't move with the speed as our brother ambassador was telling us, the agreement can remain there. Because remember, there is no timeline for individual country to do what? To ratify. Others may do it within months. Others may drag for years. But the issue is to get to the threshold of 60. That's why there was a discussion in State House Kenya yesterday about that thing. How it will come and how it will be ratified by the Kenya government quickly. So if all of us, we can sensitize our governments to ensure that that ratification process is accelerated so that we don't delay. As long as we delay it, that pandemic agreement will remain beautiful but not in force. We are together. So that is the message. So one of your takeaways is to ensure that what the ambassador has said, please actively participate in looking at the annex that is speaking to pathogen, access, and benefit sharing. And he has told us very clearly, like Africa, we have been very disadvantaged. Most of these vaccines have been produced because of pathogens from Africa. You know, Africa has been a home to so many pathogens. Yes. So many pathogens are residential in Africa. So a lot of research happens. When outbreaks happen, samples are carried away. People go, they prepare therapeutics, they prepare vaccines, they sell. They make money. They don't share. So this is the whole thing. But let me tell you, I don't know how many of you know, because we are in a diplomacy workshop. So I have to be very careful with my words. How many of you know that I think it is last week, one of the major funding mechanisms that you receive they have a new policy. I know he knows, but I don't know whether you know. And that new policy is saying that for us to give you money, funding for HIV, for malaria, for many other things, we must do what? A bilateral agreement. And the bilateral agreement is that you must give us access to the pathogen access, the materials, the genomics, and everything. You understand? So, policies, we give you money for 5 years, but you will give us those things not for 5 years, for a long period of time. Now, this is where we are saying, as Africa, how do we negotiate in these things as Africa? Because we have so many problems, economic challenges, and when we have a carrot of money here, we look at our poverty, and again, we surrender some things. So these are things we need to look at as Africans. How do we go to these negotiations? How do we also manage bilateral engagements? Isn't it? Hello? So why are you looking at me like, I don't know. But you're getting what I'm trying to say. So, before the ratification, which we don't know, I mean, when it will come into force, what we only know is the PAB system is supposed that annex should be adopted next year. But after that, the issue of ratification at the country level, we don't know the deadline. It will depend on how fast we can agree to move with speed. Like a continent, we have 55 countries. So you see, if Africa was even moving at speed and mobilizing the others, then we'll reach that place within no time. But now, with this pandemic agreement, which is not in force, what can I or what can we advise you? Number one, look at it. Because most of us have not gone through it. There are 35 articles. Look at it. Download it. Read it. If I show you my copy here, I've underlined so many things trying to understand. Going through it article by article. Look at it. Then, the kind of systems we are supposed to put in place, they will definitely require us to have national strategy on how to implement those things. But they are very good things because ultimately it's supposed to strengthen the health system. And we can now take this opportunity as member states to push for more resources to be able to attain the required what? Capacities. So we need really again to sit down, look at the pandemic agreement, bring legal minds on the table and experts, look at the existing laws within your country, whether do they allow the implementation. And then some of the things don't even require legal things. Some others, policy, guidelines, whatever. Then you try to decipher these things and see what you need to begin doing. Actually, some of the things is about strengthening your own capacities. You can do it without waiting for what? The ratification. Strengthening your own health system. Advocating for resources, ensuring all those things are happening. So, there is a lot that is cut out for you, but don't say that, in politics, I have seen when the leader of a political party has read, the followers will say, so long as our boss has read, we don't need to read. Whatever he tells us is right. But this is not the case. So these are issues of public health. And they have a serious implication in our lives. Now, I just wanted to ensure that we are getting out of this place with common understanding. Now, this PABS annex that we are talking about, if you look at Article 12, because of the inequalities that we experienced during the time of pandemic, whereby we are very behind in the queue, we are seeing the countermeasures are there, but the queue here was very long for us in Africa. So what is in the pandemic agreement that is supposed to be operationalized is what he has told us. But apart from that now, the same article says that the manufacturer will give will avail 20% of those health products, and they are either vaccines, therapeutics, or diagnostics. 20%. Out of this 20%, 10% shall be a donation by the manufacturer to WHO to be able to address issues of inequalities. And then the other 10% is supposed to be offered at an affordable price. So the issue is to try to cure the inequalities out of the production or the manufacturers that are doing this work. Then 20% get it out, make it available. Out of that 20%, 10 is a donation. Then 10% is affordable price. Read it for them. Yes, please.
Thank you very much, Dr. Charles. It's actually 12.6a. It says each participating manufacturer shall make available to the World Health Organization, pursuant to legally binding contracts signed with the World Health Organization, rapid access targeting 20% of their real-time production of safe, quality, and effective vaccines, therapeutics, and diagnostics for the pathogen causing the pandemic emergency, provided that a minimum threshold of 10% of their real-time production is made available to the World Health Organization as a donation, and the remaining percentage with flexibility based on the nature and capacity of each participating manufacturer is reserved at affordable prices to the World Health Organization. And the distribution of these vaccines, therapeutics, and diagnostics shall be on the basis of public health risk and needs, with particular attention to the needs of developing countries, and the global supply chain and logistics network referred to in Article 13 may be used to this end.
Excellent. Thank you, Ambassador. Now you can hear it not from what I'm talking about, from the agreement. It's already there. So that is supposed to help us. But let me also tell you, where are the manufacturers? Where are the manufacturers? What about if the country with the manufacturers does not ratify? Those are the issues. That's why, again, we need to ask ourselves, a continent, how do we have the manufacturing capacity in our continent? And for us to have that capacity, you must have your national regulatory authority needs to have a maturity level 3. WHO maturity level 3. If that assessment is done in many countries, they don't achieve that. But we are happy some countries have already achieved. So that maturity level 3, some are for vaccines, others are for medicines, others for something else. Now, once you reach maturity level 3, it means we can trust you in terms of safe products you are producing. They are safe, they are secure, they are efficacious, all those things. So what we need as Africa, again, is not to really think that every country should have a manufacturing plant. No. But it's ensuring that at least we have geographically distributed manufacturing plants in our continent. And we can even talk and agree. If Ethiopia, that has already recently reached maturity level 3, their maturity level 3 is for medicine. This number of medicine probably they will do. And Kenya now is almost there. If you deal with the issues, the political issues, you'll be there. Then it is easy to agree. You produce, because you want also to access market. You don't want to produce products and you're not selling. It is not of any economic benefit. So Africa countries need to talk about these things so that we see what is Rwanda that is already ML3. Isn't it? What are you going to produce? So what are you going to sell to us? What are you going to sell to us? So that again we see that we have the necessary capacity in our region to produce and ensure that we have a good supply chain that our goods can move, even in the time of emergencies. And achieving maturity level 3 also will boost the investor confidence. Investors can come and say now, if you have been able to reach maturity level 3, you have been given that license by WHO, we can bring our money. Yeah? But some countries, we have to look at those things as a region that ultimately we have at least some local manufacturing. Hello? The sugar levels are going down. Yeah? But we are talking important things. Isn't it? Now, let me see what else I can emphasize. Some of the things that are in that agreement, actually, you can continue implementing. Some of them, even within the IDSR system in countries, the integrated disease surveillance and response, you can be able to be able to implement what is required under IHR, amended IHR, and what is in the area of surveillance, what the pandemic agreement is calling us for. Right to health, again, some of the constitutions in our countries, they already have right to health. This instrument is talking about right to health. Does your legal instruments allow that? Yeah? So these are things we need to think. When we are looking at the legal issues, we look at whether some of those things would be accommodated in our countries. So we have a device here. There will be need for a gap analysis. To look at your legal instruments that are existing, do a gap analysis, a proper one. I have supported quite a number of countries on international health regulation assessment. And one of the things we have always recommended is you at least assess your legal instruments using a One Health approach and see what you have, what you don't have, and whether does it allow now the domestication of these instruments. If not, what adjustments do you need? Some countries have opted just to do some amendments. Others have been forced to repeal, not to repeat, but to come up with a new law. I was in one country whereby they were operating with an instrument of 1960. So we tried to look at how we could domesticate IHR. It was quite difficult because that thing needed just to be redone. So we had to work on a new Public Health Act, which now is able to provide room for all the things that are required. So these are things that you need to look at in your country. Some of you have very new, recent Public Health Acts that accommodate international health regulations. I think we have talked about manufacturing partnership. We need to think about those things. The other thing the financing aspect, I think once you look at the agreement, you can see actually the kind of financing that is required. We need a lot of financing there. One of the financing that is required is surge financing. You know, surge financing, that we have an emergence, then we have already a pot or an envelope that can be accessed very easily within very short period of time, day zero, and it can support emergence. So that's surge finance, very, very important. But beyond the surge finance, there is need to think about sustainable financing that will help you now to build the core capacities that are required for prevention, preparedness, response, and resilient. Yeah? So those are things that you need to look at when it comes to financing mechanisms. So there is also, apart from national level, regional level, like now EXA, IGAD, and all these other regional organizations, there's still a lot that we can be able to do around helping in a coordination of a unified African position. And this is why EXA has brought us here. Thank you very much, DG, so that we can try to solidify the African position, yeah, in the upcoming negotiation on the annex. So very, very important, these kind of engagements. I'm trying to see what else I need to mention, taking note that the sugar levels are going down. Yeah. But colleagues, now, even if I don't talk more, I think, Dr. Sohel, can you say a few things, then we hear whether they have any
Maybe I can use
comments. Okay,
the
fine.
speaker here. So colleagues, I think we can congratulate, I think as a global community, that these two things came together. I mean, the pandemic agreement and IHR amendments. But I think we also need to be mindful that I think the political impetus that led to this agreement, I think because of COVID-19. But at the same time, we need to recognize that I think none of this agreement, I think, are binding. I think these are all based on goodwill between countries, because WHO doesn't have any power for enforcement. I think is it because of this global health security, the controlling the border, controlling the trade and commerce, I think that led to this type of agreement. I think unfortunately this is the reality that we all are in. And the second aspect I just wanted to emphasize, I think there is a greater emphasis on equity and solidarity. I think equity and solidarity has a different scale. I think there is a global scale, but we also need to consider about the equity aspect in terms of access to health services within our own jurisdictions. I think if we cannot ensure equity in a routine context, in a peacetime context, we cannot expect that equity can be available in terms of service delivery during an emergency context. I think it's very, very important. And if the service is not available in routine context, that means we are itself, I think, many weak points in our healthcare service delivery. I think the question is, I think, is what? I think my colleague Charles, I think he elaborated quite a lot. I think in terms of what, I think that is the central questions. So there are two dimensions. There is a global dimension, and then there is a Africa-centered, regional and country-focused dimension. In the global dimension, you have WHO, you have Interparliamentary Union. I think the current DG is also from Africa. And you have also WIPO, World Intellectual Property Office. So these are some of the mechanisms that we can call upon, I think, for this access and solidarity at global dimension. But now, within as Africa as a continent and the countries that we have, I think I think Charles mentioned about it, I think is a scalable capacity. I think in terms of the scalable capacity, I think we need to think about how can we bring the solidarity, whether there can be a shared funding space that we can create. We cannot expect that a sophisticated capacity for vaccine production, I think, can be applicable for all countries. So we need to think about, I think, the market demand, and also the economic feasibility for developing that capacity. I think that is where we need to consider about the regional solidarity and sharing of funding space. I think the other aspect is that you can have a manufacturing. I think it's not just here, I think it's also in many other continents. Sometimes is the sector-wide capacity development is important. If there is no proper cold chain, and if the vaccine requires, for example, minus 60 temperature, that means we cannot sustain the quality to supply that vaccines to the local population. I think it also, I think Charles mentioned, I think we need to think as a overall systems capacity. I think it needs competent workforce, it needs proper information system, it needs the funding flow, and also I think considering that this investment, I think is for routine market supply, but also for developing that capacity so that that capacity can be there for emergency R&D and emergency production capacities. So just a few comments, colleagues, I think, but we as a WHO are always with you, I think, to support on this, but this is one of the most complex one. I think given that many of the capacity for this type of sophisticated production, even countries in high income countries, unfortunately, they are very, very market driven. Even the governments in those countries do not have enough control on some of those big pharma. So we need to come up with a more ingenious solution that will work for this continent. Thanks a lot. Back to Charles.
Thank you. Thank you very much, Dr. Sohel, for reinforcing quite a number of issues. So I think moderator, Dr. Connie, if there are more issues, you want us to go to the, okay.
Maybe there are some questions. We can just open the floor for questions.
Sit here. If there is no question, we shall just come down.
Yeah. The questions. I've posed questions to the colleagues here, and I haven't had answers to them. But I'll sit with you, Charles, and expect the questions to come from the floor. Yeah. You spoke about, let me just address one issue. You spoke about somebody going around now talking about in order for you to get funding from us, let's have bilateral agreements. The question that I have for the colleagues here, what does that do to global solidarity? It sounds like a stupid question, but it's very important. If you go bilaterally on issues that we're already saying, because WHO must remain at the center of health matters. And there was a reason why it was established. It was established solely for that. If you then go behind the scenes on issues that we say, in order for us, because we know, you cannot, there is a saying that was repeated many times, if you want to go fast, go alone. And if you want to go far, let's go together. And this is the whole purpose why, firstly, we established the United Nations, and then we have an agency that looks in these issues of health, which is the World Health Organization. Question is, what are the possible effects or impacts that would have on what the World Health Organization stands for, and what, as members of the World Health Organization, are doing at the current moment? Thank you. And we stand ready to respond to your questions, of course, if any. I'm not too sure if I've paralyzed you. Okay, Felix, my brother.
Thank you, Ambassador. And let me really thank you for your presentation first, and secondly, for being here and for being active in Geneva as well. I was myself witness to your skills with Eswatini and also now as a vice chair. You said negotiations on pubs have begun, if I got you correctly. So my question is, what is the starting point? Do you have negotiating text, or do members just come and suggest what they want to see in the instrument? Then, from your vantage point, do you see continuity from our delegations, in the sense that do you see the same faces that negotiated the pandemic agreement? Are they the same people involved with now negotiating the annex? Because for me, continuity is very important. You don't really want new people coming in at this point, although that can happen, but at least you need people that understand the broader context. Then finally, I think you have a time frame as the working group of 1 year. What's your own assessment? Do you think at the end of 1 year, when you make your report, you will be reporting progress, or will we be nearer concluding the instrument, the PABS instrument? Thank you, Ambassador. I had a question for Dr. Njuguna, but it's on manufacturing capacity. I think we need a totally different full workshop to interrogate those issues. But thank you both.
Moderator, I'm not too sure if you can respond.
Yes, please go ahead and respond.
Yeah.
Are there any more questions before we respond? No?
Okay.
Please go ahead.
Thank you, Felix, for the questions. I will start with the question that seems to be more simpler, but difficult. I'm not too sure if you understand me. They look on the surface to be simple questions. I'll start with the issue about consistency. I want to applaud our region in particular, the missions in Geneva, the African missions in Geneva, and also Capital, for those who bring colleagues from Capital. There is consistency. The colleagues who have been involved in the process from the negotiations on the amendments of the international health regulations, and then they also continued to be the same people to negotiate the pandemic agreement, and they are now still the same colleagues who are negotiating the annex. There is consistency, at least from most of our regional members. And then what is my thinking? The mandate that we have been given as the Intergovernmental Working Group is to deliver an outcome at the next Health Assembly in May 2026. From my perspective, I don't want to talk about perception, because perceptions, they have a problem. But my perspective of this issue is this, that firstly, we need to live up to that mandate. And failure for us is not an option, as we always say, as we negotiate under the auspices of the World Health Organization. We have always made sure that we deliver. The expectation is that if we don't have an agreement, but we still have to bring an outcome, before our health ministers in May. From where I'm sitting, there is already light at the end of the tunnel. There are some areas, of course, within the negotiations, that areas where there is already convergence in terms of what we want to appear to be contained in our PAPS annex. There is already a working draft that was prepared by the Bureau on the instruction of the IGWIC itself, because the Bureau cannot just come up with a document without the IGWIC members saying that go ahead and come up with a draft document which will form the basis of the negotiations. There's already that draft that is working on. In the last IGWIC, which is IGWIC 3, which was held last month, we already started what we can refer to in quotations as textual proposals and negotiations. That then tells you that come IGWIC 4, which is going to take place from the 1st to the 5th of December, the expectation is that we continue, the Bureau has been mandated to come up with a more cleaner text which reflects the areas of convergence as a starting point, and also have those matters which are still contentious between the parties. My response to that is that there is very much hope that we will deliver in accordance with the mandate that have been given to us by our health ministers in May of this year. I think I've answered all your questions, of course, unless I've acted like a cowboy shooting from the hip, as it were. But I think I've tried to respond to your questions. But I must add, Felix, that of course, there will continue to be areas where it will be difficult to come to agreement, at least at this initial stage, especially because we still need to have, because the members have called for simulation exercises that relates to how the operations takes place in terms of sharing those who have the experience. And for us, we have been lucky enough, the seat of the UN in Geneva, the country called Switzerland, has graciously offered a simulation exercise that will take place on the 30th of November, just a day before we start IGWIC 4. So there is already hope. We've already had engagements with manufacturers in terms of how they think, what they think about this whole thing that we are establishing. We've held stakeholders, which, of course, there is a process within WHO as to how you actually start talking to these stakeholders, because it cannot just be any other stakeholder, as it were. So there is really hope that come May 2026, we might just be celebrating another success when it comes to the PAPS Annex. Thank you.
Thank you so much, Ambassador, for that response. You've touched again on a very important issue of investing and supporting local manufacturing, and I think you summarized a lot of the key issues that we need to focus on as we move ahead. The fact that we need to take a local action to ensure that the PABS Annex is adopted, and also the need to assess local instruments to see whether they support the right to health across the One Health sphere. Another important issue, including that bilateral agreement that has been brought on the table that is tied to funding. Now, to the local delegations, do you have any questions, any comments, any issues that you'd like to be clarified? Please go ahead. Is there? Please go ahead. Please go ahead.
The problem is that you are sitting behind the delegate, so you can't see who has raised his flag or not. Yeah. You can have this.
Great. Do you have any questions or clarifications or comments? Burundi?
Thank you very much for this session. So I don't know if you have things like this, so that I can come back to French. So I see many people struggling with translation. Let me use my poor English. So my question is on the agreement on the position of Africa when negotiating. So I have participated one time in the World Health Assembly in Geneva. I saw sometimes there is no a common agreement on one element when it comes to vote. So I'm asking myself, do we have a framework of preparation of such a assembly when we have to have the common position for Africa, when we are defending the same interest? Do we prepare first before we go to the negotiation? If ever we prepare, we have the same understanding and the same position. How can we say that we have the same understanding? Because let me suppose that sometimes we can't have the same interest even within Africa. I have been in some meetings, regional meetings, where I see countries don't have the same position, even in regionally, which means that at continental level, it can happen that even in Africa, we don't have the same position. So at which percentage we can say this is really the position of Africa, when there are some countries who are not who don't agree with the majority? I submit, Chair.
Oh, okay, very important question. I will say, you want to respond to that first? Okay.
I think again, just to share the experience, not as an answer, just to share the experience from the European Union countries. So when European Union participate in World Health Assembly, I think there are two ways they participate. One is as a common position of the European Union on issues that they can agree on. So when they say that, okay, I am representing the government of France, but they also mention the countries that have came up with a common position with the government of France. At the same time, in the issues of differing views, France or any other European member state can also express their opinion. But in terms of the preparation, the agenda for World Health Assembly and all documents normally sent to all permanent mission, I think in a good time, and so that all member states can do their reviews. And if needed, I think if there's a block like a European Union or, in your case, you have a one political platform, African Union, as well as you have regional committee convened by our regional office. I think that type of platform can be, I believe, utilized. I think if there is a need for coming up with a common position for Africa. But there are examples exist from the European Union one. Thank you.
Okay, no, thank you very much for that. I think it's speaking to the same issues. I will respond to your question in this way. In Geneva, for instance, where I've been actively participating, and we have what we call the regional group. It is the Group of Africa. In that group, we have individual countries, or a country that is leading the team in terms of who is the coordinating mission at that particular time. So we have a regional position which we have to express, and then we support that, all of us will support that. If you want to speak from a national capacity, you are still allowed to do that. But there is a position which we expect that you support, even though you have your own national perspective. That is the expectation, that we support the regional position, but you want to speak at a national capacity. What then that tells you is that the regional position will take precedence over your national position, of course. That is how it works in diplomacy. You know, we support what the region is saying on those issues. And you are very much allowed to speak at national capacity. We always see that. But and then also the question about preparation, I think Dr. has already touched upon it. We meet, we discuss the agenda, and then we also even assign specific matters to individual countries, work on them, and then come with statements which we share and we approve as a region. Whosoever speaks for the region is speaking from a script which has been agreed upon by all of us. You can have your different view, which you then will want to say, I want to express this issue from a national perspective. Still allowed to do that. But otherwise, we are all expected to support the position of the region. That's why we always, and that has kept the region of Africa to be afloat in actual fact. And because we always say that unity is our strength. And we have managed to do that on a lot of aspects. Yes, of course, you may differ in terms of thinking and approach, but it's very important for you to support the position of the region. Thank you.
Thank you so much, Ambassador. I think that was a very good
So
question.
thank you very much. I wanted to ask a question as well.
Yeah, sure. Kenya, please go ahead.
Yeah, so thank you, Charles, Dr. Charles, and Ambassador. So we've seen a lot of civil societies cast aspersions on this pandemic treaty in terms of, and I think you did touch on it, that countries may be forced to even change their laws to be able to align with the treaty. But we realize out there's quite a bit of misinformation also that is also scaring some countries in terms of actively engaging in the negotiations so that we come up with a good document. So what is WHO, the Bureau, doing to counter some of this misinformation that is out there? And the push especially is coming from the civil society.
Was your question addressed to someone specifically, or I think both of you can go ahead and respond.
Yeah, Ambassador has to be here to respond to many of the global processes. But maybe just to mention, this process of coming up with this pandemic agreement was very, very open, very inclusive process. Even the civil societies were involved in the process. There were even open discussions about the pandemic. So at the national level, you have the civil societies. So as you engage going forward on domestication of these instruments, the best thing is to ensure that there is wide consultation so that you carry people on board. And especially when it comes to issues like right to health. Those are issues that are sticky, but they have to be handled. People may have different positions, but as Ambassador was saying here, even at regional level, the spirit is that of consensus building, trying as much as possible to build consensus. It will do you good as a government when you have even the civil society on board and reading from the same script because they have the right information. Sometimes people take divergent positions because of lack of information. And when people think that there is some red cards under the table, they will make their noises. But if we can put everything on the table about these processes and what we need to do at country level, then you are likely to have a lot of consensus building and people speaking with the same voice. In terms of issues of misinformation, we have to continue advocating. As WHO, we do that. We have seen, I don't know whether you saw a clip that circulated widely about somebody who came and talked against vaccines. Did you see that clip? And he was talking before a head of state, telling the head of state, don't accept these vaccines that WHO is telling you about. So you can imagine the kind of damage control that you have to do, because that president said he feels that he is almost getting converted to believe what this person is saying. And he's a scientist, but reading from a different script. So I think those voices may be there, but if we can push out the right information as much as possible to reduce the chances of people having misconceptions, the better. But when it happens, again, we must deal with the issue. It can never be swept under the carpet. If it has been raised at the level of the president, then we must again counter it from that highest level. And that's what we had to do as WHO, because it was raised at the level of a head of state. Then we had to go back, even apart from talking to the populations, start with the head of state so that we can get the head of state giving out the right information. So again, it's a shared responsibility, not just WHO, but even governments. You know very well, we need to build trust with communities, with civil society. A lot of trust needs to be built there because there is a lot of mistrust. There are many places you go, people don't trust their governments. And that's the reality. And we have to ensure that we are all pulling in the same direction in these important matters. But Ambassador, if you want to make a decision, you can do it.
Oh, so it means I'm not pressing enough. Thank you very much, Dr. Charles. Oh, you know, my response to this will be twofold. In life, there is what is called facts and myth. And all of us carry the responsibility to think very broadly around these issues. I think the first responsibility that we carry when it comes to myth is to demystify the myth. It's a responsibility for all of us. WHO does not have the mandate to force any country to do as directed, you know, especially when it comes to issues of international agreements. It is a responsibility of each country to sign, ratify, and align its laws in accordance with what is obtaining at the global sphere. So that is a myth. I will say it is a myth because it is not something that is a palaver of the WHO as an organization. Member states negotiate and agree, and WHO is there to coordinate, not to start saying to member states how they are going about to do their business when it comes to these international agreements. And of course, it's true that the civil society, they exist for a reason. We cannot start talking about what are their core mandates. And this is the more reason why there is a process within the World Health Organization itself to be saying who are our stakeholders. Because you need, firstly, to declare conflict of interest. So if there is a conflict of interest, and you cannot stop people from saying whatever they want to say, but for you is to correct the position. So there is just no way, and in my experience, I've never seen it happening, because I've participated in negotiating a lot of international agreements. And in these agreements, you are expected to implement them in accordance with your national law. And if you feel that there is no national law or framework which you can use, then you develop local legislation to deal with these issues. We spoke about, firstly, political will in terms of signature. You sign. After signing, you do the other things that follow. Once you ratify, you are obviously bound to act in accordance with what is obtaining in that particular instrument that you have signed up to. So in short, my colleague from my other country called the Republic of Kenya, we need, I think you brought in a very important issue. We need to be alive to these myths that are going around. Misinformation, disinformation, because, you know, deep fake these days. I could be talking here now, and you may find that what I'm saying will be somewhere, but not exactly what I'm saying. But it will be me talking and sitting here. That is deep fake. So there's a lot of things that are happening. Some of these things are very good. You know, digital transformation, we cannot stop it. Very important that we align and we move, because it's happening at speed and at pace. So we have to keep up with it. Then also we need to see who's behind the mic, who's talking, what is his mandate, his core mandate. Is it to actually say the opposite? If that is the case, therefore, you take that with a little bit of salt. So our responsibility, all of us, is to ensure that how we deal with misinformation and disinformation. I think our countries are ready for that, and Africa in particular. I've observed that our leaders, our governments are really working hard on these issues. And thank you for raising that, but WHO, in my view, cannot do that. It's my view. Thank you.
Thank you so much, Ambassador Dlamini and Dr. Njuguna. Now we're going to, do we have any more questions? Just a brief question before we go. Please go ahead.
Yeah, so thank you very much, presenters. I've just a short contribution. We have heard about the backgrounds and so forth, but I think now let's be very pragmatic. You know, I'm glad that we are having this global health diplomacy now. As we are coming from our countries, we are in the midst of reviewing the MOUs, the bilateral MOUs, by that funder that Charles talked about. and it's real. And they wanted us, they had given us a deadline to say if you don't sign by this date, we are not going to give you that money. But what is in that document is completely ultra vires to what we are discussing here. It's ultra vires completely to the PABS. And I am sure other countries are going to sign for it. And you know, some countries are blessed or not so blessed to have so many pathogens of interest which affect the whole continent and the world. And they might sign for those. And it's in their sovereign right to sign. But as we go back to the country, like as I'm going back, I would really need a very smart diplomatic advice to tell my principals on what it means to sign for that and to be politically correct, but also giving very sound technical advice to such a document. I might not have the powers be to disallow them to sign, but I should have given them that good evidence. So I think as we move forward, that advice is it way pragmatic, is needed. Thank you.
Thank you. Oh, one more question from Mauritius. Oh, sorry, Malawi. Malawi, please go on.
No, thank you very much. It does appear indeed that time is not on our side. The people that are being addressed to here are, of course, they're supposed to be linking technical and politicians. I was sharing an article in the front page, one of the front pages, where it's already been almost agreed and signed, same issues that Zimbabwe is raising. Is there any thinking within the WHO on convening the politicians? Because the politicians are also under pressure. I mean, World Health Assembly that we're referring to in May next year may not be too far, but whether they may really appreciate what is being discussed here. I was counting the population that is signing these documents is about 700 million people. The 15 countries, 700 million people that will be in there, and the PABS is coming out clearly that the interest, and in fact the interest is beyond the 5 years. The interest is that they get the tissues and the samples more than 5 years. Huge data. That's why I was talking about 700 million. So data for 700 million population moving and being handled elsewhere. I think quite a big risk. And does it provide survival for the WHO? What is the risk on the survival of WHO itself? Will it live? Especially that the other parties haven't ratified, or they're not party to this. In fact, they probably are not longer within the WHO. I think the urgency is also on WHO to move the agenda, especially to our politicians. I have said that politicians tend to have 5 years in most of our countries, and sometimes they want to deliver and show that 5 years they've done A, B, C, D. Maybe the technical people, some of them live beyond 5 years. They look beyond that. And so the low hanging, the politician will pick it. The long term, maybe the technical people will be looking at that.
If you have
I will make he is a lawyer. He's going to come. I'm very careful. But colleagues, from morning when we started, I raised the issue of nationalism and multilateralism. And what did I say? I said these two instruments is a success story of the process of multilateral engagement. But also I said there is a threat to multilateral systems. Why did I say that? Is as much as we have this kind of pandemic agreement that is supposed to bring issues of equity to address the inequalities that were there in the spirit of global solidarity. Not every member state, but now they are called COP in this document. COP stands for, lawyer, you can remind me, the Conference of Parties. So they are called parties, yeah? So they are the ones who will constitute the Conference of Parties. We are at a situation whereby, as WHO, we cannot force any sovereign state in any way to even to be a member of WHO. There is provision for exit. Again, not every member state or state party would agree to sign to these legal instruments. Even up to now, there are those that have refused to sign IHR 2005. There are those that they submitted their own reservations. So even for this one is the same. We have a scenario whereby we have tried to push this using a multilateral system so that there is global solidarity, but some of the key players may not be on that process. They may not agree with that. So in such a case, they also come up with their system whereby they say now, for us, we are not going to follow the multilateral, we are going to do bilateral. So the bilateral engagement, again, it is not a bilateral between WHO and that state party. It is a bilateral agreement between two state parties. So it is Zimbabwe signing an agreement with their counterpart, not WHO. So in this kind of a thing, who is supposed to decide? It is you. That's why we are in this kind of an engagement to help each other to come up to speed to understand these things. Because now you are their advisors to the politicians. You can advise them when you have also at least a better understanding. And that is the purpose of this global diplomacy, is to help us to have information that we can now use it and package it in a diplomatic way. It's an issue of balance. You are telling me not to sign. That politician will ask you, you're telling me not to sign, and I'm seeing here an envelope. And remember, you are binding your country, your millions, that you'll get the money for 5 years, then you have to hand over these rights or submit these pathogens, everything, for 15, 25 years. So it is you to deal with your governments. As technocrats, find ways of packaging all this information. But that's why I'm so happy you bring it here in Malawi. And look at those bilateral agreements. Then how do you negotiate? How do you negotiate those bilateral arguments, remembering that you are representing your republic and the millions that are in the villages? you are doing it on their behalf. So I would ask the lawyer ambassador in East Africa, we call them wakili. So wakili is a lawyer. So please, I'm telling them, I'm trying to push back that this is their responsibility. I think for us, what we can do here is to ensure we are sharing information, but at the end of the day, every state party is sovereign. Thank you.
Yeah, no, it's a very important issue here that has been raised. It really makes us to think. We need to think outside the box. There is a likelihood, where I'm sitting, of some level of disengagement in the process. There is that likelihood. You know, when you talk about probabilities, you look at the bigger picture. The bigger picture is, in pandemics, for instance, no one is safe until everybody else is safe. That is what happens. You need to look at the realities. My colleague from the Republic of Zimbabwe is talking about pathogens of interest. They are in Africa. As a matter of fact, it's not even something that you need to overly think about. There are parts of our region with pathogens of interest. And when you start thinking about these bilateral agreements, you look at the intention of the PA, especially in Article 12. It's saying to you, you need to reclaim your sovereign right over your biological materials. And these are the things that must happen. The question is, these bilateral agreements are happening behind the scenes. We don't know the contents thereof. Because now we understand that it's about funding. But the PA, Article 12, is not about funding. Not essentially about funding. It's about a lot of things. With that, you need to be thinking. But again, it goes back to the issue about, can we start talking about what sovereign nation states must do in their own jurisdiction? Certainly not. You can only but advise. The decision lies with your political leaders. You can give advice as a technician, you know, because now it's a competition between what is politically correct and what is technically correct in that sphere. But it's an individual member state that has to decide, where are we? All I'm highlighting now is there is a possibility to disengage with the process, a high possibility of doing so. So I think, as I was sitting where I was sitting before I came to the podium, I had already seen communication shared by a colleague who's saying, I'm being asked that, because pressure has been brought to bear to the individual member states to sign these bilateral agreements. You know, but it is for us to advise and for our politicians to decide if that advice leads to correct political decision. Sovereign nation states have the full right to decide what is okay for them, and whether with that you will then be able to achieve what you are setting out to achieve with the pandemic agreement, including the PAPS annex. So I think it's a delicate balance, but you need to look at it with that in mind. You're saying, what is there to achieve? Because my colleague from the Republic of Malawi is saying, usually they are in office for 5 years. They want to deliver within the period of 5 years. What we are delivering, is it future-proof? Is it sustainable? Is it going to protect the health of your people for the next generation? what happens when a next pandemic hits? So you are going to be the first on the queue to receive because Big Brother has made you to sign bilateral. We don't know. We're not going to start speculating, as to what should happen, because as lawyers, we're not expected to speculate. We can only but anticipate things. My anticipation is that there will be a real disengagement from the process. That's the danger I foresee. Thank you.
And maybe just to ask maybe Ambassador here, we have this process that WHO has tried as much as possible to ensure countries regain their rights. Because personally I've been involved in many outbreaks of infectious diseases. Some of the things that I see happening to our member states are very, very painful. Seeing blood samples taken from communities, shipped out of the country, you feel pain. But you find that it's like governments cannot put down their foot and say no. Now, this agreement was trying to come to redeem from this kind of a scenario by ensuring now the pub's annex is domesticated. It becomes a legal instrument in your country to protect you in that. So what is the implication now when, before even the pub's annex is adopted through this multilateral system, you now circumvent that process and sign another agreement? I want you to ask yourself that will you now, what will be the implication when you have surrendered your rights and then you'll go through, you'll be required to domesticate a legal instrument that is protecting your country from these kind of things. So it's something that I think requires a lot of engagements, but also bringing to the attention of politicians about the ongoing process of pandemic agreement and what it is coming to do, and especially for developing countries. So that's what I would say. You need to educate them, because some of them may not even know that there is a process that is going on. So you need also to bring them to their attention that, look, we have this agreement that has been adopted. We are part of the countries that have adopted. There is a legal tool that is coming up. We are supposed to domesticate it so that it will define clearly about when I'm surrendering my samples and information, what are the benefits. Get the point? Honestly, for us as WHO, we feel like our member states need also to rise up and be able to see what is this that you agree, what is this that you push back. Are we together? Yes. But you are sovereign states. But what is this that you can agree? And what is this that you can push back and say no in the interest of your nation?
Thank you. Any more questions? Great. A short question before lunch meet?
Yes, thank you. Apologize, we reach the workshop later. But just, I want to know if it's a suggestion or an idea. WHO, Afro, is working with Africa CDC on this question, because Africa CDC is a mandate to push our leaders and the head of states to be engaged or commitment for that in that process. And I want to know if you work together on that question.
Yeah, I think the issue of working with Africa CDC is something that is clear. We have even common frameworks we have agreed on. We have even signed instruments on how best we are going to work together. And we have no shortcut about it. We have to ensure we work in a way that we complement each other. Even the member state would want to see that complementarity, not any element of competition. Africa CDC, like for the current Mpox outbreak, we have been working together. That's why we had to establish a continental IMST and also a continental Mpox response plan, and ensuring we have one team which is based in your country, DRC Congo. Are we not having Africa CDC there and WHO? Because we are working together in this, and while even this process of pandemic, they are also involved. So we all have to use different methods and opportunities to push or to ensure that the member states, in one way or another, they have information so that they can make decisions in a more informed way. So that is the thing. But again, as we have said, and our ambassador here has labored a lot, every member state has a seat in INB. So you cannot say the INB is only for some few countries. Every country. So all these things are happening. But also you need to ensure in your countries and also in your permanent mission is also talking to each other in terms of these processes and understanding. Thank you.
Yeah, in actual fact, I want to come in and say this. For us, as the labor-based negotiators for the region, we work very closely with the CDC through the African Union Commission. They have experts which they bring, sit and discuss matters, but what resonates throughout what we prepare is the priorities for the region, not national priorities for the region. We go as a united team to be buttressing the position of African region. And Africa CDC is complementary to the World Health Organization, to our regional teams in the regions. So we work, everything is in sync, to be honest, from where I'm sitting. And I want to caution again to our colleagues in the region of Africa to be saying we need to think very, very hard about the approach that is happening currently. What does it do to our health system? Is it strengthening them? Is it only about trying to resolve certain challenges, overlooking, because again, individual member states have their individual rights to decide what is right for them. But we need to be thinking, one, if they were to give the Kingdom of Eswatini, for instance, in return for the access to our biological material, give Eswatini $30 million and the access to those pathogens for a period of over 40 years. There's something wrong there. And in actual fact, what do we get in return? Because what I've seen, just glancing through, I've seen the agreement. It's a template. They go to all these countries, they sign the same thing. All they tell you is for us to give you funding. We need the right to access specific for a number of years. Then the figures, let's forget about the figures. Does that help you as an individual member state to address your health issues? And then what is the impact of that in the region and globally? Just want for us to engage in that kind of issue. And thank you to Zimbabwe and Malawi for raising these issues. They are very critical, but it remains with you to give the correct technical advice and ask your Minister of Health to go to Cabinet prepared. I'm not saying he's going to succeed, but if you put your cards on the table, the information is there. You know, from my training, I understand that I cannot say no to somebody who is, give him advice. And then if he cannot talk, because we need to engage, if you cannot talk, I reduce it to writing. And it remains there. Nobody's going to blame me tomorrow for saying I did not, because I will take my advice. This is what I told you. Reduce it into writing, give them, and with that explanatory note, and then highlighting the dangers of having to engage. We're not going to sit here and say Zimbabwe should not sign the agreement with the funder, whosoever he may be. Certainly cannot do that. It's for you as Zimbabwe to make that call. Thank you.
Thank you so much, Ambassador Dlamini and Dr. Juguna. I think we cannot emphasize enough the impact that national interests and priorities have on those multilateral agreements. But I hope through a process like this that we will support in capacity building, we can positively influence political processes and political goodwill in such a way that we recognize that agreements such as the pandemic agreement are actually more beneficial for sovereignty than those multilateral and those bilateral agreements. So thank you everyone for your contributions, and we will now break the line for Santin. Thank you.
Dear delegates, lunch is being served in the restaurant on the left. So when we go out, we turn left and go all the way, or the other side on the patio, we go for lunch. Thank you. And we'll be back at 3 p.m.